very long without hearing about stress, isolation, unemployment, and COVID brain, just a few of the symptoms patients are handling now in the aftermath of the global pandemic. For patients, the stressors may have changed, but the need only continues to increase. Increasing insurance coverage to include 12 behavioral health outpatient visits for people under 21 years old and eliminating the use of a copay will enable young people easier access to behavioral health care. At the Alliance, our members work to keep people healthy and secure in their communities. As such, we believe LD 1531 is a good bill to recognize the critical work being done within the mental health field. Please support LD 1531 with an ought to pass vote. Thank you.
Thank you very much, Ms. Morse, and good job on the timing. And now I'm turning to the committee to ask if there are any questions for Ms. Morse. Okay, seeing none, we thank you very much for your testimony. And now we'll hear from Kate Endy of Consumers for Affordable Health Care in favor of the bill.
Good morning, Representative Tepler, Senator Sanborn, and members of the committee. Thank you for the opportunity to provide this testimony in support of LD 1531. My name is Kate Endy, and I'm the Policy Director at Consumers for Affordable Health Care, which is a nonpartisan, nonprofit organization that advocates for many people to be heard, respected, and well-served in a health system that provides coverage, access, and quality affordable care to all. Mental health is a vital component of overall health care, which is why it's crucial that we ensure everyone, and especially children, can access quality, affordable mental behavioral health services when they need them. 1 in 5 children have a mental, emotional, or behavioral health condition, but only 20% of these children receive care from a specialized mental health care provider, according to the CDC. Suicide is also the second leading cause of death for adolescents. The CDC lists cost and insurance coverage among the barriers that can make it difficult for parents to get their children the mental health care services that they need. As you've heard from others, the COVID-19 pandemic has led to an increase of social and emotional challenges for many children, including through isolation, death of loved ones, additional stress, and adverse conditions in a home, which have exacerbated mental health needs for youth. In fact, the share of emergency department visits for kids for mental health needs increased between April and October of last year, according to the CDC, which is why we fully support this bill to ensure that, to help eliminate the cost barrier for many children. I just want to point out that if the intention is to completely eliminate cost sharing for the first 12 visits, which is my understanding, the committee may want to consider revising the language in Section 2 of the amendment. As currently written, it requires coverage without cost sharing for enrollees 21 years and younger for up to 12 visits a year. And so the committee may want to look at clarifying that the level of coverage is required for at least 12 visits instead of up to. But with that note, I hope you will all join in supporting this bill, and I'm happy to answer any questions. Thank you.
Thank you very much, Ms. Endy, and thank you for that clarification. I'm sure our analysts will make note of it. Is there anyone on the committee with any questions for Ms. Endy? Seeing none, thanks very much for your testimony. And that is the end of my list of folks wishing to testify in favor of the bill. So I'm now going to turn to our folks on the call who as attendees and see if there's anyone who wishes to testify in favor of this bill who has not yet been called on. If you wish to be called on to testify in favor of this bill and have not yet testified, please raise your electronic hand. Okay, seeing none, I will move on to opponents of the bill. And first, I will call Christine Ossenfort of Anthem Blue Cross Blue Shield.
Thank you, Representative Tepler and members of the Senator Sanborn and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you to testify in opposition to LD 1531. The proposed amendment to LD 1531, as Representative Arford has noted, would require health insurance carriers to provide up to 12 behavioral health office visits without any form of cost sharing for individuals under age 21. We certainly understand the goals of the legislation. However, we do have some concerns that we would like the committee to take into consideration as you evaluate this proposal. LD 2007, as enacted last year, requires coverage of 3 behavioral health visits, 1 at no cost and subsequent 2 visits subject to copay only. As this provision has just been implemented, it's too soon to know the impact of this requirement on either cost or care. Mandated benefits represent a significant cost. Maine is struggling with a health insurance cost crisis today, and additional mandated benefits will only exacerbate that situation. As this committee well knows, the state is currently wrestling with how to strengthen and enhance affordability in the small group market, and adding new mandates that will increase significant cost is contrary to that goal and will make it more difficult to achieve. As the committee knows, under the Affordable Care Act, states may be required to defray the costs of any new mandated benefits. This proposal would not apply to Medicare or self-funded plans and will benefit less than 30% of Maine's population. Finally, we note that this has the potential to be extremely expensive. It is a mandated benefit requiring review and evaluation by the Bureau of Insurance. So if the committee is interested in pursuing this proposal, we strongly urge you to send it to the Bureau of Insurance for a mandated review. So thank you, and I'd be happy to answer any questions that you might have. And I, of course, will be present at your work session as well.
Thank you, Ms. Ossenfort. I believe we have at least one question from the committee for you. Yes, Senator Sanborn.
Thank you, Madam Chair. Ms. Ossenfort, my question is about sort of this strikes me as getting to plan design. And my understanding of the Clear Choice plan process that we just went through is that at least for the lines of business to which the Clear Choice plans will apply, those plans have already been set and we wouldn't be able to change this particular provision with regard at least to the next plan year. Is that right?
Yes, thank you, Senator Sanborn. It's an excellent point. The Bureau is about to, my understanding is the Bureau is very close to finalizing the 2022 plans. We have built our products and our rates on the most recent version that we have seen, assuming that there will be little change. So it would be very difficult to pivot and address that for 2022 at this point in time, because we are about a month away from having to submit our rate and product filings.
And just so that I'm clear, the Clear Choice plan designs do get deep enough into the weeds that they specify copays for particular categories of services so that those are the same across whichever offering plan you're offering. Is that right?
It does, and it reflects requirements of 2007 with respect to the 3 primary care and 3 behavioral health visits.
Okay, thank you. That's helpful.
And thank you, Ms. Ossenfort. I have a question too. It's my understanding that the sponsor has an amendment that she's worked on with the Bureau regarding Clear Choice and a way to amend the bill to respect the Clear Choice plans. Have you had any discussion about that? And also, it's my understanding that testimony that the superintendent is providing does not indicate that this bill requires a mandate review because it's not a change actually in the provision of benefits, but in a cost sharing formula.
So thank you, Representative Tepler. We have not seen the most recent amendment that Representative Arford described. We'd be happy to review that and provide comment. Conceptually, from what she described, I understand it would say that if it impacted the actuarial value, that if I understood correctly, basically the number of visits could be scaled back, I guess, to perhaps meet actuarial value. I would have to discuss that with our pricing team to understand what that would mean. I'd be happy to do that and bring it back to your work session. And I'm sorry, I printed a copy of the superintendent's letter, but I haven't actually read it, so I don't know what he said. I'd be happy to look at that though and respond for your work session.
Thank you, Ms. Ossenfort. We're all playing catch up, especially after our day yesterday. And I'm sure that given that you're with us most of the time, you probably have experienced some of the same long days.
Yes, I'm having a little bit of Zoom fatigue. I realized a second ago that I'd stopped my video instead of my audio.
Yes, I've had that experience. All right. Any other questions from the committee regarding Ms. Ossenfort's testimony? Seeing none, thank you for your testimony.
Thank you.
And we'll invite Ms. Pelletreau in to give her testimony in opposition to LD 1531. Welcome, Ms. Pelletreau.
Thank you. Good morning, Senator Sanborn, Representative Tepler. My name, members of the committee, my name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. I speak in opposition today to really the whole series of mandates, but I will take Senator Sanborn's recommendation and be very short here and say ditto to everything that Chris Ossenfort said. Thank you.
Thank you for your brevity, Ms. Pelletreau. I guess I would then have the same question for you. Have you seen the superintendent's testimony, and have you any response to Representative Arford's suggestion that there are ways to make this bill compatible with clear choice?
I would echo Ms. Ossenfort's response there too. I'm not familiar with the latest version and have not had a chance to discuss it with our plans.
Okay, thank you. And I know that I hope you will in time for our work session.
Will do.
Any other questions from the committee? Seeing none, thank you for your testimony. And I will turn to other attendees on the call and ask if you would like to testify in opposition to this bill. Please raise your virtual hand. Seeing no hands raised, I will ask for anyone who wishes to testify neither for nor against. Oh, I should say that first on my list would be the Bureau of Insurance. Superintendent? Welcome, Superintendent Chapa.
Good afternoon, good morning, Representative Tepler, Senator Sanborn, members of the committee. We weren't intending to testify, so I'm a little caught off guard, but I will bring Marty. I am available to answer any questions. I mean, our letter speaks for itself. We consider this a mandate, and well, it's not as outlined in the letter. So.
Okay, Superintendent, I see that Senator Sanborn has a question for you.
Okay.
Thanks for being here, Superintendent. I guess my question is about the clear choice plans, because your letter doesn't reference the clear choice plans, and I was a little bit confused by that because it seems like this law would be incompatible with the rulemaking and plan design work that you've already done.
If it's okay with the committee, if I could bring Marty Hooper in, she's really spearheaded the clear choice on this.
Sure.
Marty, I know she's on.
Yes, I think that Mr. Ritchie is bringing her on right now.
I'm moving people for Christian, but I can't see Marty. So if she can raise her hand, that would
She
help.
has her hand raised.
Okay,
Colleen.
perfect, because I can't see her there.
She's coming. I just grabbed her.
Oh, okay, thank you, Christian. I couldn't see her. Thanks.
She was mid wormhole.
Yep. Welcome, Ms. Hooper. Thank you for being here. Senator Sanborn has a question that you may be able to help us with.
So my question was just about the clear choice plans and whether it would be possible to pass this bill without upending the rulemaking that has already been almost finalized for those.
Yes, hi, Marty Hooper, the Life and Health Actuary for the Bureau of Insurance. And as in the past, any legislative mandated benefit that gets put in place, the carriers are required to add that to their coverage. So that would be my understanding of the approach. Certainly, we would recommend that any mandate be put off until, let's see, it would be 2023 to allow the carriers, as Ms. Ossenfort mentioned, the carriers are starting to design and price out their plans. They're required to be filed mid-June, so we're getting close in time. But we have been able to adjust when mandates get passed, and certainly Clear Choice anticipates that any mandates would be covered in those plans. And I guess I can speak to the amendment. Part of the discussion of the amendment was our concern for me meeting the actuarial value requirements. That's certainly a federal requirement that would impact when you start changing co-payments and cost share requirements.
So I guess that's really more my question, Ms. Hooper, because this isn't so much a mandated coverage as it is a plan design bill. This is like a mandated plan design bill that would ride on top of what we've already done with our Clear Choice. So I guess my question is more about, if you were to change this one part of your plan, doesn't that mean you also have to go and raise copays somewhere else, potentially? Because the plan design that the Clear Choice plans have put together has to sort of come together into a package. So my understanding is that there was discussion during the Clear Choice stakeholders process, at least, about offering, for example, no copays on pharmacy benefits. And then there was a lot of back and forth about which items should have copays and which ones should not on particular plans at different meta levels. Is that the sort of thing that gets worked out during the stakeholder process? for Clear Choice? Just none of us were there, so I think it'd be helpful to have more of a sense of that.
Yeah, a lot of the discussions were, as we mentioned, having to meet the AV values. So a plan is designed with certain cost share requirements, and then those are placed into an AV calculator that determines whether it fits within the range. We tried to leave some cushion there because certainly carriers have unique aspects of plans that aren't, the Clear Choice doesn't touch on every single aspect of a plan. So there is some cushion there for adjustments to the offerings, but some of them are more difficult to meet than others. Bronze is very difficult to meet because just the structure that we have right now is a fairly generous set of cost sharing requirements. But as I mentioned, we do recognize that there are mandates that might pass and might need to be included in the Clear Choice plans. So we're hoping that there's some cushion there to allow for some adjustments to those plans. Yeah, it's a very difficult process. Even the federal government just within the past few days has released the required maximum out of pocket. So we had to add that in and make adjustments to it. So, so I'm not saying it can't be done, but yeah, I agree. In the process, we tried to lay out the different cost sharing given the information that we had.
Okay, thanks.
So I'm raising my own hand to throw in a quick question. Ms. Huber, while you're here, so would it be helpful if the committee set the date on this bill if it decides that it wants it to move forward back so that it could be incorporated into the next set of Clear Choice plans?
Yes, yep, we will be reviewing the Clear Choice designs. We anticipate doing that every year to see what works. Certainly listening to stakeholders, we'll continue that process if there's any information and obviously adjusting to any new mandates, either federal or state that come through in the meantime.
Thank you. Any other questions from the committee for the superintendent or Ms. Hooper? Seeing none, thanks very much for being here. We do appreciate it. You spend a lot of time with us, so we appreciate that. I would like to ask if there's anyone else in the call on the attendee list who would like to speak neither for nor against this bill LD 1531. Seeing none, I will bring the hearing on LD 1531 to an end, and we will certainly be scheduling the work session fairly soon. So thank you. And next up, I've been asked to announce an order of bills, and I will, with subject to correction by my co-chair, say that I believe that the next bill up will be 1357, and following that will be 1539, and then 922, followed by 794 and 1614. So that is the order of bills for today, and my co-chair has indicated her agreement. So next up, we're going to turn to 1537. I'm sorry, 1357. Getting those numbers a little backwards. 1357, an act to require private insurance coverage for postpartum care. And this bill is being introduced by, oops, I don't think the sponsor is with us, or is, oh, you know, the sponsor is with us. Thank you, Senator Carney, I see you. The sponsor of this bill is Senator Ann Carney, and we will ask her to join us and present her bill. Thank you for your patience with our delay this morning, Senator Carney, and welcome.
Thank you. That's okay. We had the same issue in judiciary. So thank you for welcoming me so warmly this morning. Good morning, Senator Sanborn, Representative Tepler, and esteemed members of the Committee on Health Coverage, Insurance, and Financial Services. I'm Ann Carney, representing Senate District 29, which includes South Portland, Cape Elizabeth, and part of Scarborough. I'm pleased to introduce LD 1357, an act to require private insurance coverage for postpartum care. This bill would provide urgently needed health insurance coverage and align insurance policies issued in Maine with current medical recommendations related to postpartum care. I do want to say at the outset that I may have located this bill within the wrong section of the statute. I do intend it to apply to both individual and group policies. And so I anticipate that an amendment will be needed in that regard, and I'll work on that. Complications following childbirth include pain and bleeding, high blood pressure, lactation difficulties, and pelvic floor dysfunction. For example, more than 1/4 of US women have pelvic floor disorder with symptoms that include long-term urinary incontinence. Treatment like physical therapy can strengthen the pelvic floor muscles and improve quality of life. Private insurance coverage for postpartum care, though, is very limited and doesn't cover this and other necessary medical care. In fact, most insurance policies provide coverage based on an outdated and insufficient framework for postpartum care that involves just one office visit at 6 weeks postpartum. The American College of Obstetrics and Gynecologists issued a committee opinion in May 2018, and it was reaffirmed in 2021, titled Optimizing Postpartum Care. The opinion adopts a framework for postpartum care as an ongoing process rather than a single encounter, with services and support that are tailored to meet the patient's individual needs. This new framework is often referred to as the, quote, 4th trimester of care. The opinion states, and I did want to let committee members know that there should be live hyperlinks in the testimony that I filed online. The opinion says, rather than an arbitrary 6-week check, the American College of Obstetrics and Gynecologists recommends that the timing of the comprehensive postpartum visit be individualized and woman-centered. To better meet the needs of women in the postpartum period, care would ideally include an initial assessment within the first 3 weeks postpartum to address acute issues, followed up with ongoing care as needed, and concluding with a comprehensive well-woman visit no later than 12 weeks after birth. Insurance coverage policies, and this is what the ACOG, as it's known, recommends, insurance policies should be aligned to support this tailored approach to 4th trimester care. Unfortunately, health insurance and reimbursement models conflict with this new framework of postpartum care. An analysis in the New England Journal of Medicine titled Postpartum Care in the United States, New Policies for a New Paradigm, points out that, quote, complex health insurance systems and maternity care reimbursement models are at odds with universal high-quality postpartum care in the United States. And in particular, the bundled payment model for maternity care may impede equitable access to care. A reimbursement model that drives healthcare providers and patients to a single office visit at 6 weeks is simply not adequate to treat things like pelvic floor disorder that require ongoing physical therapy and the many other issues like postpartum depression, high blood pressure, lactation difficulties, and serious cardiac issues that can arise in the postpartum period. LD 1357 would require private insurers to shift from coverage based on the single 6-week visit to coverage that aligns with the 4th trimester care model recommended by the American College of Obstetrics and Gynecologists. This shift can improve maternal health outcomes without significant premium increases. And the New England Journal article, which again, there's a hyperlink to in the material, points to cost-effective approaches to delivering postpartum care that are being used in other countries. The 3 months following birth of a child are wonderful and challenging. New moms are recovering from childbirth, caring for an infant, sometimes navigating pre-existing medical conditions, and simultaneously preparing for return to work at the end of the 12 weeks of family medical leave. Insurance coverage that supports the 4th trimester care model will allow Maine women to successfully transition to parenthood, a stable health condition, and return to work. Thank you for your thoughtful consideration of LD 1357. I'm happy to answer your questions.
Thank you very much, Senator Carney. Are there questions from the committee for Senator Carney? Seeing none, we appreciate your bringing this bill to us. And we will now turn to other legislators wishing to testify in favor. And I believe we have Senator Sanborn speaking for Senator Brenner, who couldn't be with us this morning. Go ahead, please, Senator Sanborn.
Let me just pull up the testimony. So members of the committee, I am speaking for Senator Brenner, who represents District 30, including Gorham, most of Scarborough, and part of Buxton. As a nurse midwife, being present at birth was the highlight of my journey with a family, with a woman as she became a mother, sometimes for the first time, sometimes for the third. But what I enjoyed more than anything as a provider were the postpartum visits. These visits were opportunities to process the labor and birth, explore the new mother role, and set the trusting basis for ongoing well-woman healthcare. The postpartum period is a particularly vulnerable time for new mothers, both for themselves and their child, as they learn to navigate parenthood and all that comes with it. Between the lack of sleep, the pediatric visits, the immunization schedule, and a plan for how to go back to work and afford childcare, the last thing a new mom is considering is herself. She has embarked on the phase of life which includes knowing selfless love. And for many, this means their own healthcare comes last. Missing the postpartum follow-up visit could mean a missed opportunity for a woman to connect with her nurse midwife to set up a long-term follow-up for high blood pressure, diabetes, or a debilitating depression. Long-term, this can have grave impacts on child development. A well-cared for, healthy mother will parent better and arrive each day and night with more agency to care for her family. A woman who misses the opportunity to follow up in that first 2 months under our current model may very well be lost to care. And these women in Maine and across the country are more often than not Black, Indigenous, tribal, or Latina. Racial and ethnic disparities are magnified in maternal child health care when women lack access to care. Postpartum care plays an invaluable role in the long-term health of mothers, their children, and their families. And we need to do all we can to ensure every Maine woman has the ability to access it. And I ask that you join me in supporting LD 1357. Thank you and be well.
Are there any questions from the committee for Senator Sanders? No, I guess that probably won't work very well, will it? Okay, since Senator Brenner isn't with us, we won't ask Senator Sanborn to stand in her place with questions. And I will turn to the attendee list to see if there are any other members of the legislature who want to testify on behalf of this bill. And seeing none, I will turn to other proponents of the bill. And first on my list is, I'm trying to figure out which way does this go? Mr. Moran.
Good morning, Representative Tepler, Senator Sanborn. I believe my first response when you said Mr. Moran was, "Oh crap, I'm first." So, so I saw there's a lot of testimony on there. I'm not going to go over what Senator Carney put in her testimony. As you can see from my testimony, it's a combination of things. I have I'm Dan Moran, Director of Communications and Government Affairs for the Maine Medical Association, by way of introduction, live in Gorham. I've included the 2018 ACOG committee opinion, which, as Senator Carney said, was reaffirmed in 2021. It actually built upon a 2016 opinion. I have a summary of changes in my testimony from that document, so you don't have to read through the entire document, even though it's attached to my testimony. And also, you heard about an arbitrary 6-week check that's in that testimony. And I thought it appropriate to add the testimony of one of our members, Connie Adler, a physician who testified earlier this session on a bill to provide affordable postpartum care in the Maine Care program. And I thought especially important in her testimony talked about that 6-week mark that is currently covered. There's nothing magical about the 6 weeks, as she writes in her testimony, which is also attached to mine. She talks about then it's common to begin contraception at that visit, but she's run into situations where because of either no coverage or inability to make an appointment, they don't actually get that contraception and that important appointment after the 6 weeks. And then one of the issues was postpartum depression. You're not necessarily going to find out about postpartum depression within that first 6 weeks. So that's why it's important to have comprehensive long-term care postpartum for patients for postpartum depression and other issues, and just overall checkups, including substance use disorder. You don't want a new mother certainly falling off treatment for substance use disorder if that's something that she's facing. So she writes there are other conditions as well, of course, that are problematic in that first year: mastitis, thyroiditis, deep vein thrombosis, pulmonary embolisms, and much like no questions were sent to Senator Sanborn, I'd be happy to get clinical questions from our members before the session, or have an expert such as Dr. Adler at the work sessions, should you prefer. Thank you, and I'd be happy to take other questions or gather more information that you may be requesting from us.
Thank you very much, Mr. Moran. And thank you for respecting time limits really well.
Thank you.
Are there any members of the committee with questions for Mr. Moran? Seeing none, thank you for your testimony. And we will next call Megan Marquis of China.
I don't see Megan on the call.
Okay. Thank you very much, Mr. Ritchie. And her written testimony is available. So we'll call Hannah Lamprey of Kennebunk. Hi, Ms. Lamprey, welcome.
Hi there. I'm just trying to minimize my screen here so that I can view my document. Okay. Hi there. My name is Hannah Lamprey, and I'm a Kennebunk, Maine mother of 2 girls, age 6 and 3. After a challenging birth and postpartum experience with both of my girls, I became acutely aware of the lack of accessible support that enables birth givers to fully heal from pregnancy and birth. It was impossible to ignore. For me, like many others, the largest challenge was undoubtedly insurance coverage for the services I needed to do so. And because I know that I am not the only mother that has a story that sounds like mine, I am here today to shed light on the realities of life after birth and the current landscape of postpartum care and insurance coverage. Here is my story. After a textbook pregnancy with my second child and without any warning at all, I almost died. Due to internal tearing immediately after birth, I experienced a severe postpartum hemorrhage. With intense care and 7 units of donor blood that I will forever be thankful for, my life was saved. I shudder to think about the myriad ways that the lack of adequate care in this acute time could have affected not only the outcome of my life, but that of my children, husband, our families, friends, coworkers, etc., for the rest of their lifetimes. However, upon discharge from the hospital, I was jarred to find that the level of care and accessibility to services I needed to fully heal from that birth experience basically vanished. I was in need of both physical and emotional support. My life still depended on it. But the financial cost of these healing lifelines was out of reach. And to this day, I have unhealed injuries that cause me to not be able to participate in certain activities that are at the core of who I am as a person. I'll never forget the moment when a provider assessed my injuries, agreed that they were severe enough to warrant surgery for correction, and then immediately followed up with, "But the chances of insurance covering this procedure are slim to none." I walked away from that appointment defeated, accepting a future where I only exist as a half-expressed version of myself, unless I could come up with the $35,000 that the corrective surgery would cost. Imagine her in your mind. A newly postpartum mother with a toddler and a newborn to care for, now walks around this earth as a shell of herself. She nurses her newborn around the clock despite the pain in her belly. She plays on the floor with her toddler despite the pain in her pelvic area every time she sits. She wears the face of a happy mother, but she is nothing of the sort. Yes, she loves her babies, but no, she is not whole, not even close. And now she begins to not love herself. And slowly, atom by atom, she fades away. She is now at risk of losing herself yet again, not by blood this time, but by her own hand. She battles her mind daily, and this becomes her normal, only it is not normal at all. To bring a child to this world should not require that we leave our own health and wellness behind, ever. Not only do I support LD 1357, but I vehemently deny any possibility that postpartum care moving forward for birth givers in Maine does not improve. The health of our birth givers, our babies, our families, and our communities relies on it. A change must be made. Resources are only as relevant as they are accessible, and with the changes we have the opportunity to make with this bill, I am certain that the accessibility, relevancy, and utilization of postpartum care that allows Maine families to thrive will become the status quo. I have come to terms with the fact that for some types of support, I've missed the boat, but I refuse to accept that this will be anyone else's story moving forward. Please consider my testimony in regards to LD 1357. We have an incredible opportunity to make meaningful change here, and it is long overdue. Thank you.
Are there any questions for Ms. Lamprey? Yes, Representative Matheson, please go ahead.
Thank you, Madam Chair, and thank you, Ms. Lamprey. I actually don't have any questions. I just wanted to say thank you for coming to and giving your testimony.
Thank you very much.
And next, Representative Quint.
Thank you, Madam Chair, and thank you, Ms. Lamprey, for being here. I think it's very brave because a lot of people don't like to talk about this topic. So thank you for sharing. And I don't want to get too personal into your situation just because of your privacy, but since you are here testifying, were you able to receive treatment, or is this something that you're still fighting for and struggling with insurance companies over?
In regards to pelvic floor, I was able to receive some level of treatment, but unfortunately, I dropped off of the number of visits that I was allotted, and I still have symptoms that affect my daily life, specifically in regards to fitness and exercise, which is a huge component of my mental health and wellness routine. So I'm constantly battling that push and pull. And in regards to my unhealed diastasis recti, which is that abdominal wall separation I was referencing in regards to my abdominal pain, I had diagnostic testing and then was told that there was nothing further that they could offer me unless I was willing to pay out of pocket. So no, that is definitely still an unresolved issue that insurance will not cover.
Thank you again for your testimony. No further questions.
Thank you very much.
And now I will turn to Representative Evans.
Thank you, Madam Chair. I don't have a question. I want to thank you, Mrs. Lamprey, for coming to provide your testimony. This gives a purpose and a reality of what people are experiencing day to day. So I really appreciate you being here. Thank you.
Thank you very much. I appreciate that.
Thank you for sharing your personal story with us, Ms. Lamprey. It certainly gives us a perspective on this bill. Now we will turn to Ms. Homan-Sprague, Dusty Homan-Sprague of the Maine Women's Lobby, to testify in favor of LD 1357.
Okay, hello. Looks like I made it in. Good morning, Senator Sanborn, Representative Tepler, and members of the committee. I'm happy to be here with you today. I also have to just thank Ms. Lamprey for her moving testimony, and I don't think that I can add anything more powerful than what she did. What I will say, on behalf of the Maine Women's Lobby, we advocate for public policy that increases the health, wellness, safety, and economic security of Maine women and girls. And LD 1357 is the kind of proposal that's right at the heart of our mission. So thank you to Representative Carney, or Senator Carney, for sponsoring this bill. Maternal health and mortality in Maine and in the United States is among the worst in the developed world. We're one of the only countries in the world without paid family leave, the only developed country without universal health care. And because of these lack of systems, we experience significantly higher rates of maternal mortality and decreased postpartum health. And as others have said, this falls disproportionately on women of color, Black and Indigenous women, low income and rurally located women. One of the key factors in the struggle that women face before and after birth is that our systems tend to focus on the infant, and the physical and emotional work of pregnancy, labor, delivery, and postpartum recovery just tends not to be addressed routinely and systematically. This is true to such an extent that it is not yet a given that postpartum depression and pelvic floor injuries or other normal and commonly occurring health needs of the person giving birth are not seen as a typical extension of the birth experience and therefore covered by private health insurance. This structural oversight has so many implications that you have heard about, that you will hear about, but I just want to lift up the fact that in 2020, the United Health Foundation state rankings found that Maine was 50th in the country for rates of depression and anxiety among women of childbirth rearing age. More than 1 in 3 experience depression. And we know that there's a direct connection to this and postpartum health, which has lifelong implications. So thank you for considering this bill, and I hope that you will vote yes on LD 1357.
Are there any questions from the committee for Ms. Homan-Sprague? Seeing none, thank you very much for your testimony.
Thank you.
And we'll now turn to Heather Drake of Cape Elizabeth.
Getting my screen settled. Thank you, everyone. Good morning, Senator Sanborn, Representative Tepler, and the esteemed members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Heather Drake. I'm a resident of Cape Elizabeth and a public health professional, and I'm here to testify in support of LD 1357, an act to require private insurance coverage for postpartum care. As a public health professional, I know the importance of providing optimal care to mothers in the postpartum period, given the numerous health issues that can and will arise. The majority of mothers will experience stress, anxiety, bleeding, and incontinence. Postpartum depression, as mentioned earlier, is a serious health concern with consequences for not only the mother, but her new infant as well. 20% of mothers will stop breastfeeding before their 6-week arbitrary checkup. These are a sampling of health issues that require more than a single medical visit to address and should be addressed prior to 6 weeks. Unfortunately, as you've heard from many others, current standards of care recommend one single visit 6 weeks post-delivery. This bill will enable new mothers experiencing these health concerns to receive the care they need, beginning at 3 weeks and in an ongoing manner to appropriately address their health needs. Of utmost importance, this bill will require that this care recommended by the American College of Obstetricians and Gynecologists be covered by private insurance, reducing financial barriers and cost burdens. As a new mother, I have experienced firsthand the inadequacies of our healthcare system and its poor treatment of new mothers. My prenatal care and delivery experience was top-notch, but after the birth of my son, it was as if my health and well-being were no longer relevant. My discharge instructions were to simply watch for heavy bleeding and take it easy. See you in 6 weeks. While I was lucky to have a complication-free pregnancy and delivery, I did and am suffering from pelvic floor complications and still over 6 months postpartum. At my 6 weeks check-in, where I didn't even receive a physical exam, and that was delayed due to scheduling conflicts on the provider side, I expressed concern with urinary incontinence and was advised to do Kegel exercises. The advice was that if it got worse, to call for a physical therapy referral. If you've ever had to deal with leaking urine while walking or an inability to hold in urine, you don't really want to take a wait-and-see approach. Putting on my public health hat, the goal is to prevent health complications, not wait for them to get worse, leading to the need for more care, more expenses, and taxing of our health system. I did advocate for myself and scheduled a physical therapy appointment that was also put off for several weeks due to holiday snow and scheduling. Unfortunately, my first PT bill was almost $400 with a request to come weekly. I simply couldn't afford this and had to end treatment. My new treatment plan involved searching the internet and physical therapy posts on Instagram. In other countries, pelvic floor therapy is a part of postpartum care and is covered by insurance. It should be here too, along with addressing mental health, lactation, high blood pressure, and other pregnancy-related complications as outlined by ACOG. So as both a public health professional and a new mother, I believe these inadequacies in care and lack of health insurance coverage need to be addressed. We should take better care of our mothers, and we can take better care of our mothers. I thank you for your time and urge you to vote in favor of this bill.
Thank you, Ms. Drake, for your testimony. Any questions from the committee for Ms. Drake? Seeing none, we appreciate your personal story as well as your professional opinion. Thank you. And we will next hear from Michelle Boyer of Cape Elizabeth in favor of the bill.
Oh, you can be right there, sweetheart. Good morning.
We welcome the visits of young people as well as their parents.
Well, that's my daughter, Ella. Thank you, committee members, for your time this morning. My name is Michelle Boyer, and I am the mom of 2 girls. And I wanted to speak in support of LD 1357 because I'm a mom and I've given birth twice. A single 6-week checkup postpartum with a medical provider is not enough. After the birth of my second daughter, I had severe anxiety that I managed on my own, but often felt very lonely and scared, even though I had a supportive husband and friends. We need to provide new mothers with more resources, and that's what this bill is asking for. In 2016, after the birth of my second daughter, I sought pelvic floor physical therapy to address urinary incontinence. Just to paint a picture for you, I couldn't turn on the shower without peeing my pants. So my doctor referred me to a pelvic floor physical therapist, and that's when my recovery, but also the battle with my insurance company began. I held private insurance through Blue Cross and Blue Shield, and my claims for this type of physical therapy were initially denied. I called BCBS and asked them to send me the policy paperwork that showed where this type of care was not covered. Once I received the paperwork, I was able to read it and research it. The paperwork actually said it may not be covered. And so I filed an appeal, and reluctantly, Blue Cross Blue Shield approved my claim. I was allowed 12 visits in 36 months. This same plan allowed me to go see the chiropractor 30 times in 12 months. Needless to say, 12 visits wasn't enough for me. I needed more time and more therapy, and for that, I have paid out of pocket. At this point, thousands of dollars. It's 2021. Let's start sending the message to women that we understand the enormity of childbirth, and we're here to help them heal after birth. In my work, I have the pleasure of working with moms-to-be and new moms, and the stories that I just told you about myself are abundant among moms. So many women struggle with anxiety, pelvic pain, urinary incontinence, pain with sex, and the list goes on. Insurance coverage is hard to navigate, or care isn't covered at all, and many women put off care because of financial reasons. My own mother, who's in her 70s, and many other mothers that I've heard from in that generation are dealing with these issues too, because they never got the help they needed either. So let's stop the cycle now of women being physically and emotionally hurt during childbirth and feeling ashamed or scared about it for most of their lives. Moms in that position don't have the best footing for raising their children. This isn't just a woman's problem. We need to have strong mothers. Thank you for listening to my testimony.
Thank you very much, Ms. Boyer, for sharing your personal story and your professional experience with us. Are there any members of the committee who would like to ask a question to Ms. Boyer? Yes, Representative Quinn, please go ahead.
Thank you, Madam Chair, and thank you, Ms. Boyer. I'm going to be the question girl throughout this. But thank you once again for coming to testify. I know it's a difficult topic, and so I'm really impressed with the women coming forward to speak on this issue. Was the physical therapy that you received, did that work for you, or are you still having to deal with that, or was that successful?
The initial 12 visits was not successful, and since then I have continued care on and off as needed, and it is helpful.
Okay, great. Thank you so much.
Mm-hmm.
Any other questions from the committee for Ms. Boyer? Seeing none, once again, thank you for sharing your story with us. And Ms. Boyer is the last person on my list to speak in favor of the bill, except I see a raised hand. So we'll call Elena Marchessault, I hope I pronounced her last name correctly, into committee to testify in favor of the bill. Welcome, Ms. Marchessault. If you can unmute yourself and turn on your video, you're with us now. Great, thank you.
Thank you very much. Good morning, Senator Sanborn, Representative Tepler, and other members of the committee. My name is Elena Marchessault, and I live in Falmouth. I'm a mother and a doula, and I support LD 1357. Birth givers need additional support after childbirth, and this bill would provide access to the specific care they need to thrive after giving birth. Too many people are just surviving during this time, and the data speaks for itself. Rates of postpartum depression and other mood disorders like anxiety and OCD are as high as 1 in 5 birth givers in some demographics. Up to 48% of birth givers in the USA report their birth experience as traumatic, affecting their lives and relationships for years if symptoms remain untreated. I just learned the stats on pelvic floor dysfunction, 1 in 4 birth givers. And I'd like to add that I always assumed that peeing myself would be a normal part of life after giving birth because so many women talked about it as I grew up. But I have a very different story than so many other brave women who are here today and other birth givers. I gave birth to my son in June of last year. And in my training as a doula, I learned about the value of pelvic floor physical therapy in preparation for birth and for healing after birth. Even though my insurance did not cover a cent of my therapy, the $780 that I spent was worth it. And being proactive prevented greater costs from incurring. What did this mean for me? I had 2 appointments before giving birth, focusing on exercises to relax my pelvic floor muscles, which can expedite labor and reduce trauma to those tissues during birth. I diligently engaged in my exercises, and my labor was atypically short for a first child, and I experienced no perineal tearing at all. The fact that I did not tear accelerated my healing in those early weeks. I had 4 appointments after giving birth, doing gentle exercises during the early postpartum days, and more challenging exercises as my evaluations confirmed that I was gaining strength. Because of my therapist's expertise, I was able to heal my core faster than I would have been able to on my own. My son is just 10 months old as I read this, and I am in control of my systems. My systems are not in control of me. In 2004 and again in 2014, I tore my left ACL. My insurance did not hesitate to cover therapy before and after my surgeries. What is different about the pelvic floor? When our body's tissues experience trauma, they must be rehabilitated in order to function properly. Normal pelvic floor function does not include urinating when we cough or sneeze or the prolapse of our pelvic organs. And as a new parent, we should not be overwhelmed with constant worry, anxiousness, or feelings of self-doubt. Imagine how many people who must return to work just after 6 weeks after birth are suffering from incontinence, depression, and other issues. We must make postpartum care accessible to Maine families. And we can look to other nations for the precedents they have set around postpartum care. The implications of this basic care mean that millions of people can not only survive, but thrive after giving birth. When parents thrive, our children thrive, and that outcome speaks for itself. As a mother, as a birth worker, and as a Maine woman, I thank you so much for your time on this critical matter, and I ask you to vote yes on this bill. Thank you.
Thank you, Ms. Marcia. So is there anyone on the on the committee who has a question for Ms. Marcia? So. Seeing none, thank you so much for your testimony. And is there anyone else on the call who wishes to testify in favor of 1357? Seeing no other raised hands, I will turn to those in opposition to the bill, and we'll ask Ms. Pelletreau to offer her testimony. Welcome back, Ms. Pelletreau.
Thank you. Good morning. Representative Tepler, Senator Sanborn, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify in opposition to this bill. I will say from the outset that I understand very well what these women are talking about. I am a mom, and birth can be very traumatic. And there can be long-lasting consequences. That said, right now, health plans do cover a level of postpartum services. Sounds like they're not covering everything that these women that you've heard from, that we've all heard from, have sought. But there is a requirement under the ACA for both pre and postnatal care coverage, which all the plans meet. So that said, to the extent that the committee does decide to move forward, this is a fairly broad mandate. It should be studied by the Bureau of Insurance for impacts to premiums. And it would only apply to about a quarter of the population of Maine, which is the fully insured population, and not to the other categories of those covered, like Medicaid, Medicare, federal employees, self-insureds, et cetera. So I'll stop there. Happy to take any questions.
Questions from the committee for Ms. Peltro? I have a brief one, Ms. Peltro. Can you outline for us exactly what is currently covered under the ACA for postpartum care? And if you can't do that today, it would be helpful for the work session, because we're hearing people are only getting one postpartum visit.
Yeah. So what I'd like to share with you is the language in the essential health benefits coverage. This is what is required to be covered in the state of Maine under essential health benefits. Now, I don't know if it's the level of detail that you're looking for. This is printed from the Maine Bureau of Insurance website, but here's what it is. It's just 2 lines. Obstetrical services and newborn care provide benefits for prenatal and postnatal care, delivery of a newborn, care of a newborn, and complications of pregnancy. Now, in my request to the health plans for a little bit more information, I did get some more information about just what is covered, and I will give you an example here. And this actually links to the American College of Obstetrics and Gynecology, which you've heard some references to already from the proponents. But this is what is covered by one of our larger plans. The visit includes an interval history and physical exam to evaluate the patient's current status, as well as her adaptation.
Excuse me, I'm sorry. Is this one of the plans that would be affected by this bill?
Yes, it is.
Okay, thank you.
And let me offer one other, well, I'll hold on that and just tell you. Adaptation to the newborn, specific questions, including those relating to postpartum depression and breastfeeding, an evaluation of weight, blood pressure, breasts and abdomen, a pelvic examination and pap smear, if appropriate, contraceptive counseling and management. That is what that plan covers. And I'm happy to go back and try to see if that is common across all of our members. But as I said, they all have to have some coverage. But I suspect it doesn't go as far as what the proponents are looking for.
Thank you. And I see there are several other questions from the committee. First, I'm going to turn to Representative Melorano.
Thank you, Madam Chair. Thanks, Ms. Pelletreau. So you listed off just then quite a few items and issues, potential issues, but it sounds like it's supposed to be covered all in one visit, the way because you said the visit. So it's just the one visit essentially that has to cover all of those.
I think that is, yeah, I think that is typical. Okay. And it is typical to have it, bundled. If someone's having a baby, it's typical for the whole, I'm calling it a procedure, but the experience, so the services associated with that experience to be paid for as a bundle.
In one visit, essentially.
I think so. Yeah. I think that is what's typical.
Thank you.
Mm-hmm.
Representative Quint.
Thank you. Hi, Ms. Pelletreau. If you could, with the listing that you did, I heard nothing about the pelvic floor dysfunction that most of these women testified about. And so if you could please get more information, how difficult it is if they need that service, and how difficult is it for them actually to get approval for that? Like once they're denied, what's the appeal process like? And what's the overall number of people that are then approved for it? Exactly how bad does it need to be for them to get help with their situation? I would appreciate that. Thank you.
I'm happy to get some more information on that. Frankly, that might be a question you also want to pose to the Bureau of Insurance if they've gotten complaints in this area or appeals. But I will certainly ask and bring back what I can for the work session.
Thank you very much. I know it's kind of putting you on the spot because you're the first one opposed, so you kind of get everything at once. But this is, I'm actually throwing it out there for everybody listening in. If you have that information for me, I would absolutely love to have that. Thank you.
Okay, Senator Sanborn, please go ahead.
Thanks. So I have a similar question, but I'm going to frame it a little bit differently, which is whether physical therapy for the purpose of healing birth injuries is treated somehow differently or more limited than physical therapy for other injuries, because I think pelvic floor treatment is physical therapy. And then I have a sort of related question with regard to diastasis recti, which is one of the complications of pregnancy that one of the folks who testified talked about. My understanding is that it is almost always considered cosmetic and denied due to medical necessity, even when a mom might be able to literally feel her intestines through her belly. So it's not treated as a hernia, even though that is effectively what it is. I would love to know a little bit more about what, why those injuries are treated differently because they're arising in women due to pregnancy as opposed to due to a hernia or something like that. So if you could just get us a little bit more information, I think those are two of the big areas with regard to postpartum care that are quite costly. An extra office visit, probably not all that expensive for us to mandate, but I would really like some more feedback on those other issues. Thanks.
I will take them back. I would note, I think it's not uncommon to cover the physical therapy as a way of avoiding surgery being needed. Because my sense is that the surgery is often not covered. So I will take it back.
I'm sorry, I was muted because the phone is ringing incessantly here. Representative Arford, please go ahead.
What compelling testimony we have just heard. My question for you, Ms. Pelletreau, and by the way, thank you so much for being with us, and thank you, Madam Chair, for recognizing me. My question for you is, we regulate such a small percentage of like 22 to 25% of the insurance industry. If we were to make the changes that this bill requires, I'm just curious about this. If the state was to make those changes, in some instances, does this influence the plans, the rest of the 70% of the market, which these women may well be regulated by, may be insured by? Does it sometimes, in some instances, influence the federally regulated plans making the same changes if we were to make the changes ourselves with the state regulated plans? I'm just curious about that.
Yeah, I don't have any data to support this, but I'm sure it does. I'm sure it does influence, maybe not so much what MaineCare covers, but I don't think it's uncommon for employers to note what is required coverage in the state in which they're doing business. So it may not be required per se, but I do believe there's some influence.
So in other words, if we were to pass a bill like this, it could actually have much further reaching impact than just within our 25% of the insurance market. Potentially.
All I can say there is it would not be required.
Thank you.
Thank you, Ms. Pelletreau. And we will look forward to hearing some more information from you at the work session if possible.
Very good.
And next I will turn to Bruce Garrity speaking in place of Ms. Ossenfort for Anthem Blue Cross Blue Shield. I hope I have that correct. Welcome, Mr. Garrity.
Thank you, Representative. I am Bruce Garrity. I'm testifying on behalf of Anthem in place of Ms. Ossenfort, who I know will be providing written testimony. I've also made note of the questions that the committee members have asked, and will ask her to provide additional information. The only point I would make, and it is a point that has been made by Ms. Pelletreau, but I do think it worth mentioning. These are really difficult issues. They're always difficult issues when you have to make a determination on mandating additional coverage. I do believe this is the kind of situation where input from the Bureau of Insurance after an analysis, mandate analysis, can be of assistance. And of course, there is the question that the committee always has to address, which is, on the one hand, you do everything you can to control costs. On the other hand, anytime a mandate is proposed, it increases costs, and that's not an easy task. With that, I'd be trying to answer any questions the committee might have, and thank you for letting me speak, Representative.
Thank you, Mr. Garrity. Any questions for Mr. Garrity? Seeing none, we would appreciate your taking those questions back to Ms. Ossenfort, and we will hope that the plans can help us understand better the situation here. Okay, so seeing no questions from the committee at this point, I will turn and ask if there is anyone else on the Zoom who would like to testify in opposition to this bill. Seeing no hands raised, I will turn to anyone who wishes to testify neither for nor against. I have no one listed, but perhaps there is someone in the Zoom. There is one. Oh, I'm sorry. Yes, I believe it's Ms. Cook, who would like to testify neither for nor against. I did know that, and then I forgot. So I'm sorry, Ms. Cook, welcome, and please go ahead.
Thank you. And good afternoon now to Senator Sanborn and Representative Tepler and members of the committee. And it's my apology for having registered after the deadline this morning. So thank you for acknowledging me. So I'm here on behalf, as usual, on behalf of Community Health Options, and I'm testifying neither for nor against LD 1357 this morning. As you all know, Community Health Options is Maine's only nonprofit co-op health insurance company. We offer insurance in the small group, individual, large group, and also through an administrative services organization. And with so many of these mandated benefits bills, the issues are very difficult and really a matter of public policy, as you all know, for your committee and the legislature to decide what has to be covered through private fully insured insurance. We wanted to provide you with a little information about our coverage and what is required at the through the Affordable Care Act, and encourage you to look deeper through a mandate study through the Bureau. So we provide members with postpartum care in the weeks following the birth of a child and support a mandate study to explore the impact that this bill would have on mandated benefits and potential impact on premiums. Currently, the United States Preventative Services Task Force, you'll often hear us call it the USPSTF, provides a B rating for depression screening in pregnant and postpartum women and counseling interventions for postpartum persons at increased risk of perinatal depression. Services rated.
Ms. Cook, you froze for us.
Am I back?
You are now back.
Yes. I am very sorry. I'm here in the wilds of Portland, Maine, and with an unstable broadband connection. I'm not sure where you lost me, but I was trying to tell you about what is already required under the Affordable Care Act for your information as you consider this bill. Under the USPSTF, postpartum depression screening in pregnant and postpartum women and counseling interventions are given a B rating, and anything with a B rating or above under the USPSTF requires health plans, qualified health plans, to provide those services without cost sharing. My frozen screen may have cost me some time, Representative. The Affordable Care Act also requires carriers to provide women enrolled in qualified health plans with multiple services listed on the Health Resources and Services Administration, HRSA website. Those services include women visits, screening for gestational diabetes, HPV, STI, and HIV counseling, contraceptives, and associated counseling, including breastfeeding support. All of these and other services provided by HRSA are also provided without cost sharing. All coverage offered by community health options are qualified health plans and provide the preventative services listed above. We also provide coverage for obstetrical services and newborn care, which include medically necessary prenatal, delivery, and postpartum care. We recognize that the weeks following birth are critical to long-term health and well-being for women and their infants. We encourage the committee to request a mandate study to determine what additional services carriers would be required to cover if the recommendations outlined in the Optimizing Postpartum Care opinion are adopted, and what financial impact, if any, those would have in health insurance in Maine. And I'll just note that in our testimony, we have provided you with some links that hopefully provide some additional information as to where these different requirements under the Affordable Care Act are listed, in case that's helpful. I now have a better understanding, I think, based on some of the testimony beyond what's required, sought in the bill. And I would be happy to take back the questions you have to Community Health Options to see what I could find out. But I think that often that is what a mandate study would determine, is what additional coverage would be provided and how much that could potentially add to premiums. So thank you for taking our testimony.
Thank you, Ms. Cook. Any questions from the committee for Ms. Cook? Now, we would appreciate any additional information you can provide for work session on current coverage, particularly for the two issues that Senator Sanborn outlined. Is there anyone else on the Zoom call who wishes to testify neither for nor against LD 1357? Seeing none, I will bring the hearing on LD 1357 to a close, and we will power through committee at one more hearing at least before we take a break, because some of our people who have to give testimony are pressed for time. So I'm going to ask everyone to hang with me and invite Representative Madigan in to present her bill, which is LD 1539. An act to provide access to fertility care. Thank you for being here, or at the Cliffs of Moher, Representative Madigan.
Welcome
Please,
to my Zoom background.
go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the Committee on Health Coverage, Insurance, and Financial Services. I'm Representative Colleen Madigan, and I represent part of Oakland and part of Waterville. I'm here today to introduce LD 1539, an act to provide access to fertility care. This legislation is designed to provide comprehensive insurance coverage for fertility diagnostic care and treatment, as well as for medically necessary fertility preservation. Currently, the majority of Mainers do not have access to fertility coverage. This leaves many individuals and couples having to pay for out-of-pocket fertility care. Many can't afford to even try to achieve their dream of parenthood because treatment can cost tens of thousands of dollars. Unfortunately, I can relate. I have infertility. When it was possible for me to have treatment to attempt to address this and have a child, my insurance did not cover fertility treatment, and I didn't have the money to pay for it. I paid a lot of money for the health insurance I got through my employer, and when I needed it, it was not available. The desire to have a child is a basic part of human life. This bill will not help me personally. It is too late to help me now, but I don't want anyone to experience the heavy grief that comes with infertility if they don't have to. Becoming a parent is one of the most fundamental human aspirations. So it is very emotionally and physically challenging to deal with fertility struggles. The stress can be magnified by the financial worries caused by a lack of insurance coverage. These people are paying for private health insurance so that it will be there when they need it most, but in this case, it is not. The lack of widespread fertility coverage in Maine not only negatively impacts the patients that need this vital care, but it also negatively impacts our state economically. Maine and Vermont are the only New England states that do not have fertility insurance law. Passing this bill would help us to be competitive with our neighboring states as it relates to attracting and retaining a young workforce. Thank you very much. I look forward to working with you on this bill, and I have just a couple other things to add. You should have received a friendly amendment, I'll call it, that has to do with access to some help for people who may be trying not to pass along genetic disorders, and so may need fertility care in that case. And then the other thing I just want to say is this is a deeply personal thing and difficult for many people experiencing infertility to talk about. So there's going to be people coming after me that I just want to say that I honor you, and I see you, and I recognize you, and I understand how brave you are coming forward to talk about something that often people can't talk about. And with that, I'll be happy to take any questions. I can't hear you.
Shoot, I'm sorry. I have been having a little trouble with on and off of mute today, Representative Madigan. I apologize. I wanted to ask the committee if they had any questions for you. Seeing none, I do thank you for bringing us this bill. And next, I'm going to turn to other members of the legislature who'd like to testify in favor of this bill. And first up is Senator Brenner, our own Senator Brenner. Please go ahead, Senator Brenner.
Thank you, Madam Chair, and honorable colleagues of the Hcifs committee. I'm pleased to be a co-sponsor of LD 1539, an act to provide access to fertility care. As a nurse midwife, I'm pleased to testify before you today in support of this bill. It will provide private health insurance coverage for fertility treatment and for fertility preservation. Having held the hand of devastated women as they struggle to decide their course forward through infertility when insurance coverage is not available, it's a double dose of despair. As a legislature, we have the capacity to help with the insurance coverage component by passing LD 1539. Data shows that 1 out of every 6 couples experience infertility, so chances are you know someone who has been personally impacted. I certainly do, and maybe it is even you or a member of your own family. I think all of us are familiar with fertility treatment, including but not limited to IVF. You may be less familiar with fertility preservation, which are medical procedures that enable people to protect their future ability to become a parent when they are facing a medical condition or medical treatment that is known to impair their fertility directly or indirectly. However, the coverage in this bill does not include so-called elective or social fertility preservation. I signed on to LD 1539 because we want Mainers to have access to high quality fertility care in order to try to achieve their dream, in order to try and achieve their dream of a healthy baby. We want this care to be guided by the patient and the provider working together to make decisions based on clinical best practices. When individuals and couples do not have insurance coverage for fertility care, these choices are clouded by financial concerns. Their decisions about whether to even try to grow their family or how they will grow their family is often made based on what they can afford, not other factors. I ask that the committee vote ought to pass on 1539 and support family building in Maine. Thank you.
Thank you,
I just want to echo Representative Madigan's sentiment about all the women to follow whose stories are going to be pretty profound and probably emotional. And I'm glad that we're making space for them today.
Thank you, Senator Brenner. And I do want to say to folks who will be testifying that there are a lot of women signed up to testify. We will listen to you carefully. Please know that if committee members turn off their video, it may be because they're getting a bite to eat for a moment, have to run to the restroom really quickly, and it is absolutely not out of disrespect. So we know this is an emotional topic, but we ask everyone to keep their testimony to 3 minutes so there's an opportunity for as many people as possible to speak. I will be using the timing clock, but if you are in the middle of a very intense story, I may let you go a bit beyond that, but I may have to interrupt if it goes on more than that. So please understand, we just need to get through our work, and it is absolutely not personally directed at you. I do want to ask if there are any other members of the legislature who wish to testify, because yes, I see Senator Daughtry, and she would like to join us to testify in favor of this bill. Welcome, Senator Daughtry.
Thank you, Representative Tepler. Thank you, Representative Tepler and members of the Hcifs committee. My name is Maddie Daughtry. I am the Assistant Senate Majority Leader, and I represent Senate District 24, which are the communities of Brunswick, Harpswell, North Yarmouth, Freeport, and Pownell. And I am pleased to be a co-sponsor of LD 1539, an act to provide access to fertility care, and to be here to support this bill and others who are here to speak in favor of it. The World Health Organization, American Medical Association, as well as many other global and national organizations define infertility as a disease. However, there is still widespread lack of insurance coverage in Maine and nationally, which results in severe inequity in fertility care. Improving access through LD 1539 would help address such disparities. Struggling to become a parent is one of the hardest things that someone can experience. To go through this with the added stress of a lack of insurance can be unbearable. In addition to providing vital access for individuals and couples in Maine who need fertility care, This legislation will help our state to be economically competitive with our neighboring states, namely Massachusetts and New Hampshire, who already have fertility insurance laws. I have to add, I've been contacted on this issue quite a lot by constituents. And one thing that always resonates with me that I think, Senator Brenner and Representative Madigan spoke as well, is the hesitation in their voice when they start to share their story. And you can see oftentimes, not only is this something that's deeply personal, but sometimes they feel that there's an element of shame, that they had this dream of becoming a parent their entire life and they've hit this roadblock. And whilst, I'm not here to share the stories, I want to make sure that I'm amplifying them. And for many of them, some of the stories that were the most heartbreaking is when they've discovered they're struggling with infertility and have health insurance, many folks have been unable to pay for this care. It's been so astronomically expensive that they've had to choose between their dream of being a parent and being able to continue to just survive, to put food on the table. And, this is an issue, these are people who are dreaming of becoming parents. And it's something that, should be part of our whole holistic medical system. I've heard so many stories of, folks really hoping to be able to move forward and not being able to have their own child. And I have to say, I'm also speaking out for this bill personally. I will most likely, one of my greatest dreams is to be a mother someday, and I am actively looking forward to that day. But realistically, I'm on a timeline that I will most likely be an older mother. And I know this is something that I will be dealing with. And when I look at planning for my future and hopefully my future family, access to this care will make this something that's possible and make it, something, help me achieve the dream of being a mother. So I urge you, for women out there, to please support this bill. And I'm also asking you personally, this bill would, make it possible for many of my friends to be able to be parents and potentially one day for me to be a mother. So I urge the committee ought to pass on LD 1539. I'm happy to answer any questions as well. Thank you.
Thank you, Senator Daughtry. Any questions from the committee for Senator Daughtry? Seeing none, we appreciate your testimony. And we will now turn to the proponents of the bill who are not members of the legislature, starting with Susan Speckhart of Falmouth. And I will be running the 3-minute clock. Christian, will Ms. Speckhart be joining us?
She should be in the wormhole.
Ah, okay, thank you. Oh, yep, she's coming through.
Sorry, that was a long wormhole or whatever you call it.
Sometimes they do see, it does seem to be a long shift over to the panel. I apologize. Please go ahead, Ms. Speckhart.
Sure. Hi, Senator Heather Sanborn, Representative Denise Tepler, and members of the Hcifs committee. My name is Ashley Speckhart, and I am a pediatric oncologist. I live in Falmouth and have been practicing in the Portland, Maine area for approximately 2 decades. My current practice is devoted to the health of childhood and young adult cancer survivors. And on their behalf, I ask that you vote in favor of LD 1539. The individuals in my practice are primarily between the ages of 17 and 40 years of age, and they have received chemotherapy or radiation therapy for either a cancer or chronic condition that necessitates that type of treatment. What has become very apparent to me over the last 2 decades is that there is both a financial and health cost of cure. Most childhood, adolescent, and young adult cancer survivors or conditions that require this therapy will have or have a chronic health condition that affects their current life. And for some of these individuals, it is infertility. Sperm or egg preservation, storage, and infertility treatment would provide these individuals the opportunity to have their own biological children. Unfortunately, due to the financial cost, this is not an option for some individuals. Medical coverage for fertility preservation, storage, and treatment would give these individuals access to fertility treatment and may lessen the long-term consequences of their cancer therapy. I strongly support LD 1539 and act to provide access to fertility care as this will significantly lessen the hardship that cancer survivors face following treatment. Thank you for your time. I'm certainly happy to answer any questions that you might have.
Thank you very much, Ms. Speckhart or Dr. Speckhart. Does anybody have any questions for Dr. Speckhart? Seeing none, we appreciate your testimony. And next up, I will turn to Elizabeth Wolf.
Good morning.
Welcome, Ms. Wolf. Good morning.
Hi, Senator Sanborn, Representative Tepler, and members of the committee. My name is Dr. Elizabeth Wolf, and I'm an OBGYN resident physician in Portland. I strongly support this act. As has been mentioned, infertility is a medical illness. The lack of insurance coverage for these readily available treatments equates to about 10% of the reproductive population of Maine, or roughly 24,000 families in Maine being denied access to recommended and approved medical care. I've seen severe repercussions caused by lack of coverage firsthand. Lack of insurance coverage forces couples to make decisions based more on financial concern than medical recommendation. This can lead to higher risk pregnancies and poor health outcomes that strain the medical system. Take, for example, the mother of twins that I delivered several months ago. This woman had elected to transfer 2 embryos instead of 1, as was advised, because each transfer cost her $21,000 and she could not afford to go through the process twice. While transferring more than 1 embryo increases live birth rates, it is often used as a cost-saving procedure that can lead to high-risk twin and higher order pregnancies. And this is exactly what happened. As a direct result of her twin pregnancy, she required delivery by cesarean section, a procedure both significantly more morbid for the mother and much more demanding of healthcare resources. In this particular case, not only did she require surgery, but the outcome was life-threatening. After the twins were born, she started to hemorrhage. Her uterus had been so distended from growing 2 fetuses instead of 1 that its muscle tone was no longer adequate to stop the bleeding. She lost 5 liters of blood, required 3 transfusions of scarce O-negative blood, multiple rounds of medication, and required 4 nights of recovery in the hospital instead of 2. This could have all been avoided if she had had the financial flexibility afforded by insurance coverage to transfer only 1 embryo, but she did not have that opportunity and had to take risks. My career goal is to continue to practice in Maine, but if fertility care continues to go uncovered by insurance, our state risks young physicians like myself seeking career opportunities in states more dedicated to maternal health. Maine has an aging population, and attracting young families is paramount to our ability to grow and maintain the type of community that makes this state such a great place to live. If Maine's truly dedicated to providing medically necessary care to all of its constituents and growing its young population, it should offer insurance coverage for fertility diagnostic care, fertility treatment, and medically necessary fertility preservation. Without this act, Mainers will continue to suffer. I ask you to please strongly consider the health consequences on your electorate if fertility care continues to go uncovered. Thank you for your time and consideration.
Thank you, Dr. Wolf. We appreciate your testimony. Any questions from the committee for Dr. Wolf? Seeing none, we will next turn to Mary Spring. There she is.
Good afternoon. My name is Mary Spring. I live in Bradley, Maine, and I am in favor of the bill and amendment to provide access to fertility care. January of this year, my husband and I had to move to Boston for several months. I was pregnant and was considered so high risk. Brigham and Women's and Children's Hospital were both monitoring my pregnancy. I was not allowed to return home back to Maine, and we had to find an apartment to live in. March 1st, I gave birth to a beautiful baby girl at 37 weeks by C-section. Her name was Zora Grace. It's a picture of her. She survived 9 days. She would have been 2 months old this past Monday. She died of a rare genetic disorder that my husband and I are both carriers for, called Pearson syndrome. It is a recessive disorder, which means that every pregnancy, we have a 1 in 4 chance that this could happen again. After she passed, we were given 2 options for other pregnancies. One would be IVF, where they would create a probe for the disease and they would do a pre-implantation genetic screening to pull out all of the effective embryos. The other option would be to conceive naturally, do a test called a CVS, which is much like a amniocentesis. And if the pregnancy is affected, we would have to terminate the pregnancy, which means we would lose another baby. And we would have to do this again and again until we got an unaffected pregnancy. Clearly, IVF is the safer option to prevent more heartache. However, my insurance company has an explicit exception that says that they will not cover any infertility treatment. Although I'm not infertile, it's still seen this way and it's still billed that way. Looking at purely a financial aspect, the process of having and losing Zora costed my insurance company over $500,000. 300,000 of it was being Zora's 9 days in the NICU. However, they won't even consider an IVF treatment that would cost a fraction of that to prevent this from happening again. Not to mention the therapy that my husband and I have to go to deal with the trauma and the PTSD we are struggling with right now from losing our daughter. I ask you guys to look through the lens of my experience. I'm not infertile, but my husband and I are one of the people who carry a mutation on a gene. This bill and amendment on this bill would change our family's lives. This bill would allow us to have a baby where we were not able to, where we wouldn't have to worry for 3 months if this baby would die of the same fate Zora had. We would not need to have an abortion because we would have IVF and we would know that the future of our baby was healthy. By passing this act, you would be giving our family and other families like ours opportunity for genetic testing. Thank you very much for your time.
Thank you very much for sharing your story, Ms. Sprang, and we're really sorry for your loss. Is there anyone on the committee who has a question for Ms. Sprang? Seeing none, we do appreciate your sharing this very deeply personal story, and we hope that Zora's memory will be a blessing to you.
Thank you, guys.
And I will turn next to Ms. Schneider of the American Cancer Society Cancer Action Network to testify in favor of the bill.
Good morning. Can you hear me?
It's a little difficult. Ms. Schneider, can you get a little closer to your... Say it again?
Is this better?
Yes, thank you.
Okay, sorry. Thank you. And I'm going to be brief because I know there are a lot of people here to testify. And I'm providing this testimony in support of 922 and 1539. So I won't be back for 922. As you know, my name is Hillary Schneider. I'm the Government Relations Director for the American Cancer Society Cancer Action Network. We would like to thank all the brave people who are testifying today. I will just sum it up in saying, I hear a lot about supporting childhood cancer and young adult cancer. And if you would like to support childhood cancer and young adult cancer, this is the bill you need to support. I'd also like to say that in 2021, an estimated 10,500 children ages 0 to 14 and 5,090 adolescents ages 15 to 19 will be diagnosed with cancer in the United States. Maine's childhood cancer incidence rate is 21.3 per 100,000 compared with the national rate of 18.5. The incidence rate of childhood cancer in Maine has been rising over the past 10 years. The treatments, as you've heard from Dr. Speckhard, for many of these children and younger adults may directly impact their ability to produce children. I'd also, in my testimony, outlined some of the reasons why that's the case. I'll also say for some cancer survivors, fertility is not affected by treatment, but by age. This is because there's a risk of birth defects when a woman becomes pregnant while getting or after receiving some types of chemotherapy, radiation therapy, and hormone therapy. In some cases, the risk can last for a long time, making getting pregnant a concern even years after treatment ends. In general, women are usually advised to not get pregnant during treatment and may be told it's best not to get pregnant afterwards, depending on the treatment and situation. I'd also like to say this is just not about women, that male cancer survivors who father a child, the evidence risk for them is not as clear, but many doctors will still advise against fathering a child during active treatment, just in case, meaning that they also, with their partner, will need fertility services. For these reasons, fertility services are an important medical question for many young cancer patients. As you've heard, after reviewing their options, most people ask themselves if they can even afford these options. Many of the tests that diagnose fertility are covered, but treatment costs are often not. Cancer is a scary experience full of anxiety and fear. While we are always mindful that any new patient protections may have a fiscal impact on the state, coverage of fertility services not only provides options to be able to have children even after treatment has resulted in temporary or permanent infertility, but also comfort that such a basic human need can be fulfilled, allowing all those impacted by cancer to focus their efforts where they belong, on getting better. Thank you, and I urge you to vote yes on this bill.
Thank you, Ms. Schneider. Any questions from the committee for Ms. Schneider? Seeing none, I will next turn to Mariah Pfeiffer of Lewiston.
Let's see. Hi. Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. My name is Mariah Pfeiffer. I'm a resident of Lewiston, and I'm here to urge you to support LD 1539. The bill is both personally and professionally important to me because I'm a registered nurse working in labor and delivery here in the state, and because I have a rare genetic disease called hereditary leiomyoma and renal cell carcinoma, or HLRCC. Among other things, HLRCC means that I have many uterine fibroids at an early age and will require an early hysterectomy. And the presence of these rapidly growing fibroids in my uterus not only makes getting pregnant harder, but it also limits the window of time I have in which to get pregnant. When I was diagnosed, this news catapulted me into a series of intense stress and pressure of having to think strategically, not only about how important being a biological mother is to me, but also about the financial savvy required to save for the reality of future surgeries to treat the fibroids, as well as fertility treatments. I was told when I was diagnosed that I should get pregnant as soon as possible to increase my chances of being able to have a pregnancy before the hysterectomy. But unfortunately, life just doesn't always work that way. So the reality that IVF and/or fertility preservation and its associated costs will be a part of my journey into motherhood has changed how I approach my work, my thoughts on whether I can even be a biological mother, and my financial needs. In many ways, that financial worry has been life-limiting. And it was shortly after I decided to move back to Maine after years away that I was diagnosed with HLRCC. And in that time, I've seriously considered moving back to my hometown in upstate New York, where I know that insurance plans are required to cover IVF services, at least many of them are. And then on a professional note, as a labor and delivery nurse, I'm just like to echo what Representative Madigan mentioned about the fact that, here in Maine, we need more babies and young families. Our birth rates consistently lag behind the national average, and we depend on in-migration to maintain our population. And I also know that very few people in the state have the privilege to take advantage of IVF, both because of its limited geographical access, as well as the fact, being that there are only 2 clinics,
And then the fact that in a state where we have a really low median and average income, IVF is even more unaffordable here than elsewhere. And labor and delivery units across the state are at risk of closing in part because of low birth rates, which in turn endangers the health of many Maine mothers who may need to travel further for obstetric care. And finally, Maine is actively losing prospective young families and folks like myself who may elect to move to surrounding states that do require coverage for IVF. However, I'd prefer to build my life here in Maine, and I know that I'm not alone in that. So I urge you today to support LD 1539. Thank you for your time.
Thank you, Ms. Pfeiffer. Any questions from the committee for Ms. Pfeiffer? Seeing none, we appreciate your testimony. And next we'll turn to Jessica Willett of Lewiston.
Hello.
Welcome, Ms. Willett.
Good afternoon. I first feel like it's necessary to say, due to the testimony I'm about to give, the background noise of a little 10-month-old I wish could say was mine. I'm a nanny, so you will hear that in the background. I am working today. I apologize. My name is Jessica Willett. My husband Ryan and I live in Lewiston, Maine, born and raised here. We couldn't imagine living anywhere else. We are proud and true Mainers. But for the past 6 years and counting, we have been struggling with infertility and have seriously considered moving to Massachusetts, where we could have the fertility coverage that we so desperately need and cannot receive here in Maine. Because of that lack of coverage, going through our fertility treatments here in Maine has placed us in tremendous debt. After 2 unsuccessful rounds of IVF, we are left with upwards of $30,000 in loans to pay back with nothing to show for it. With endometriosis and male factor infertility, couples like us sometimes need 3 or more rounds of IVF to be successful. I turn 40 next month, and my window to have a child of my own is rapidly closing. Without any coverage and with the enormous debt we are left with, we cannot afford to try again. I find myself thinking, I wish we had moved years ago. We might have had a family by now. LD 1539 may not pass in time to benefit my husband and me, but it gives me peace to share my story in hopes that it may help future Mainers in trying to have the family that they so desperately desire. Please vote that this bill ought to pass. Thank you.
Thank you very much for your testimony and taking time out from your workday, Ms. Willett. Any questions from the committee for Ms. Willett? Seeing none, we do appreciate your sharing your story. And we will next turn, well, I will say that Ms. Kurta of Cumberland Forside had to leave. So the committee, I'm just drawing the committee's attention to her written testimony in favor. And we'll next call Stephanie Nichols of Gorham in favor of the bill.
Good afternoon, Senator Sanborn, Representative Tepler, and esteemed members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Stephanie Nichols. I'm a second grade teacher in Cumberland County and live in Gorham. My family has lived in Maine for 5 generations. My husband and I have chosen to call Maine home, but the issue of infertility has challenged our perspectives about what that means, calling Maine home. We have decent insurance plans. My husband's plan allowed us up to $2,000 assistance for adoption coverage, but when the word infertility is attached to anything, we pay 100% out of pocket. Fertility care is necessary. It impacts our ability to have children, but as I learned in the waiting room of a hospital in Massachusetts, fertility care can also be a matter of life and death. Opportunity Maine tax credits and other programs exist to encourage young Mainers to stay and work in our community, but without fertility access in Maine, it can be a difficult choice to make. Massachusetts offers fertility coverage to its residents through a state mandate, and in 2020, New Hampshire passed SB 279, providing infertility coverage to its residents. It was even quoted in a newspaper at the time that the New Hampshire law would be beneficial to their economy because residents of Maine would travel for fertility care. Clinics assume that you will do whatever it takes to afford treatment, a second mortgage, for example. Deeply personal medical procedures reduced to economic gains. There are no clinics in Maine that could perform the infertility services we were told we needed. The lack of access to care I needed in Maine led me to believe I wasn't worthy or was somehow less than deserving of a child. We debated moving out of state solely for the fertility coverage. Maine has been failing us. As a teacher, it feels impossible to justify time off for many reasons. I've rushed back to Maine early in the morning from out-of-state clinics many times, so not to miss a day of school with my students. Then I was pregnant. My blood was monitored in Massachusetts and New Hampshire clinics every 3 days. If not for this frequent monitoring, we wouldn't have known so early on I was having an ectopic pregnancy. The day my pregnancy ended, I sat for hours alone, terrified, in a room of a Massachusetts hospital while my husband waited in the car due to COVID-19. It was the most traumatic moment of my life, and I still have nightmares about it. I wish I could have received this emergency treatment in Maine, my home, as my world fell apart. We regularly ask, why us? But then we ask, when? When will Mainers see legislation similar to that of our closest northern New England neighbors? What does this lack of adequate fertility treatment say to the people of Maine? Thank you for taking the time to consider my testimony. I urge you to please support LD 1539 as ought to pass. I'd be happy to answer any questions you might have.
Thank you for sharing your story, Ms. Nichols. And are there any questions from the committee? Seeing none, again, thank you for your testimony. And I will next turn to Emily Nason-Belgard of South Portland.
Hello, can you hear me?
Belgard, yes, we can.
Thank you for taking the time. My name is Emily. I'm from South Portland, Maine, and I'm here to ask you to please support LD 1539. About 2 years ago, my husband and I decided we wanted to start a family. We just bought our first home, and we were excited about the future. Over the previous years, I'd watched my sister go through 6 rounds of fertility treatment and to have her daughter, and my sister-in-law go through 3 rounds of fertility treatment to have their son. They were fortunate enough to live in states with insurance policies that covered their treatment. I knew living in Maine, I would not be so lucky. And their situation was my biggest nightmare. But infertility affects 1 in 6 people. Statistically, I thought, I'm fine. They're the statistic and not me. But after a year of trying, we discovered my husband had some medical issues that would prevent us from ever getting pregnant naturally. And I was 1 in 6. After speaking with both our insurance companies, begging them to add coverage, applying to grants and scholarships, looking into second jobs, and even considering moving to Massachusetts, where there is coverage, we hit one dead end after another. My husband and I are both hardworking people. We have good jobs and live comfortable lives. But we had just bought a home and we're in no position to spend $20,000 on fertility treatment. No one is in that position. So we took out a loan with an insane interest rate because we had no choice. And the worst part is the pressure. For most people, if you get a negative pregnancy test, it's a disappointment. Most people say, well, that stinks, but fingers crossed for next month. But for us, a negative pregnancy test means thousands of dollars wasted, countless hours spent getting poked and prodded and injecting ourselves with hormones for nothing. And our only option is to put on a brave face, borrow more money, and keep going. The mental and physical toll this takes is indescribable. My husband and I still haven't had our miracle baby. I'm currently taking 6 pills a day, 4 suppositories, and an injection to make our dream come true, all with a $20,000 debt looming over us. But even when that wonderful day comes, our child will be at an immediate disadvantage. Despite having good jobs, we will have to spend the first 5 years of our child's life paying hundreds of dollars a month towards this loan. We will need help from our parents with childcare, and will most likely have to empty our savings to pay for daycare. We're not looking for a handout. We know this bill won't pass in time to do us any good, but we never want another couple to go through what we're going through. This is about healthcare. Fertility is healthcare. My husband and I aren't doing IVF because we want a genetically perfect baby or a certain gender. We're doing this because we literally have no choice if we want to start a family and stay in Maine. Other states have taken the necessary steps towards covering this treatment. I hope Maine will join them in acknowledging that this should be covered. Thank you for your time.
Thank you very much, Ms. Bellegarde. Are there any questions from the committee for Ms. Bellegarde? Seeing none, we appreciate your sharing your story.
Thank you.
And we'll next hear from Mary McNulty of Brunswick. Welcome, Ms. McNulty. You're on mute still. Can you unmute yourself?
Is that better?
Yes, it is.
Okay, I'm currently sitting here waiting to receive acupuncture to my infertility. So,
Ms.
his
McNulty.
wife to my husband, Ryan. Hello.
Hi, you kind of fuzzed out for us there. Actually,
Okay.
I'm going to suggest that you turn off your video to present your testimony.
Okay.
Because it might be more clear.
Can you hear me now?
Kind of. Let's
Can
see.
you hear me now?
We're getting a little weird, like wah wah in the end.
Is that better?
Yes, it is. Please go ahead.
Okay. I apologize. I'm sitting here waiting for acupuncture and I was going to testify no matter where I was today. My name is Mary McNulty. I hold a lot of titles, but the one I'm most proud of is wife to my husband, Ryan, and mother to our constantly moving, happy 15-month-old daughter, Penny Matilda. We reside in Brunswick and we love it here. And I'm speaking today in hopes that it will help pass a bill that would support thousands of families in our great state of Maine. My husband and I were married in the fall of 2017. And like a lot of newly married couples, we knew we were ready to start trying for a family as soon as we could. Before I get ahead of myself, it's important to mention that I knew at the age of 16 that I have what is called PCOS, polycystic ovarian syndrome. I'm sure by now you have heard a lot about this diagnosis. It is one of the most common causes of female infertility, affecting 6 to 12%, as many as 5 million of United States women of reproductive age. Knowing this may affect our chances at getting pregnant without medical interventions, we wasted no time and decided after 4 months of trying to conceive naturally to work with our providers, utilizing ovulation-inducing medication, as well as interventions known as IUI or intrauterine insemination. After 9 very difficult months of failed attempts to get pregnant, our provider gave us the news that we would be unable to conceive without using IVF. I won't attempt to put into words how difficult it was to hear that news. While grieving the loss of a typical conception, we were then provided with the news of the costs of IVF that it would bring. It has been over 2 years since our initial consultation, and I still remember sitting down with the financial team at our fertility center. When we discovered that in order for us to simply have a child would cost us upwards of $20,000, we had no idea how we were going to afford this. I felt completely broken. I felt helpless. I blamed myself. These are experiences thousands of Mainers are enduring every day due to the fact that our state does not require insurance companies to provide infertility coverage. Ryan and I went through months of testing, monitoring, injections, suppositories, follicle checks, ultrasounds, appointments, phone calls, and emails. We were lucky enough to have 4 healthy embryos from our retrieval and decided to go through what is called a fresh embryo transfer. Sadly, that embryo did not take in a successful pregnancy. On top of the hardship that our failed embryo transfer brought, we were faced with the reality that after spending well over $14,000 on interventions we just received, we would now have to spend another $4,000 to move forward with another embryo transfer. We are very lucky that our transfer ended up in being Penny, our daughter. Yes, we are the happiest we have ever been now that we have our daughter. However, let's take a pause and talk about the financial trauma not having the coverage took on us in our future. When we started treatments, we had no idea how we were going to afford the cost. We were both working full-time jobs. I'm home full-time now with our daughter, but who can afford to just drop $14,000 on something that we had to have? We had no other option than to put almost all of our fertility expenses we accrued onto credit cards. Brian's mother gave us $10,000. Can you imagine starting out your pregnancy with over $20,000 in debt prior to your baby even coming into this world? And then also having to come up with the money for your delivery in a hospital. Not all families are as lucky. For most, the financial burden is where their fertility journey ends. Not everyone has a credit score that allows them to use credit cards to pay for IVF. Not everyone has family members that can provide them with large sums of money. I hope that the people hearing and deciding on this bill today will realize that for many, this bill is more of a need than a want. Thank you very much for your time.
Thank you for joining us, even as you go about your busy day, Ms. McNulty. Any questions from the committee for Ms. McNulty? Seeing none, we appreciate your being with us.
Thank you so much.
You're welcome. And next up, we'll hear from Kate LeBlanc of Resolve New England.
Good afternoon. Hi, everyone. That was a relatively quick trip through the wormhole. So as you said, my name is Kate Weldon LeBlanc. I've been the executive director of Resolve New England since January of 2015. RNE is a nonprofit organization that provides emotional support, education, and advocacy for all those in New England that are struggling with fertility and family building. We've been serving New England for over 40 years. RNE is a strong supporter of this pro-family legislation, LD 1539, and the amendment that was mentioned previously related to preventing genetic diseases like you've heard about this afternoon. In addition to those courageous friends and colleagues that are testifying live today, many local, regional, and national organizations have also submitted written testimony. My husband and I struggled with infertility. Our biggest dream was to be parents, but fortunately we live in Massachusetts and had insurance coverage. Without it, we're not sure we would have been able to afford IVF, and we're now the extremely grateful parents of a daughter through IVF who's now 13 years old. We want more Maine residents to have access to fertility care so that they can be able to try to grow their families in the state that they love, again, as you've been hearing today. Currently, 19 states across the country have fertility insurance laws, including all the New England states except for Maine and Vermont. As you've heard, the bill passed in New Hampshire in 2019 with strong bipartisan support. It passed the New Hampshire Senate unanimously. It received support from both sides of the aisle, in part because legislators recognized that policies like this help attract and keep wonderful young families like you're meeting today virtually in your great state. When signing the bill into law, Republican Governor Chris Sununu noted that including fertility care benefits in healthcare plans would help retain young workers, and said that this is a goal that they should all be paying attention to. Typically, the concern raised about bills like this is one of cost. I would argue that Maine is already paying for the lack of this coverage. As you've seen and heard in today's testimony, many individuals and couples in Maine are going deeply in debt to try to make their dreams of parenthood come true. This is making them put off other investments like saving for a home or retirement. It's making them consider moving to neighboring states to secure this life-changing insurance coverage. This is also making financial concerns impact their medical treatment decisions, such as transferring more than one embryo, which can lead to higher healthcare costs. Please vote that LD 1539 ought to pass and we look forward to helping in any way that we can.
Thank you, Ms. LeBlanc, sorry. Any questions from the committee for Ms. LeBlanc? Seeing none, we appreciate your testimony, and we will next turn to Ben Lannon of Boston IVF.
Thank you to the members of the committee. I know it's been a long session, so I appreciate your willingness to stay focused on this important issue. I apologize for my informal attire. This is not a gimmick, but I'm actually in the office today doing procedures and wasn't able to reschedule based on the timing of this meeting. I also just wanted to thank all of the brave people who have testified so far. I work with this population every day, and I know how hard it is to share these stories. And also just to say that this is definitely not just a women's issue. Infertility is something that affects men and women equally, and family building is an important part for all couples, male, female, gay or straight. So with that, I'd just like to say I'm Ben Lannon. I'm a reproductive endocrinologist and infertility specialist. I have been practicing in South Portland for the last 10 years. And in that time, we have helped Maine families achieve over 1,500 babies. Many of our patients are speaking today. These are children that go on to enter school in Maine, play in youth sports, and enrich the communities in which they live. Their pictures fill a wall in our office every year as families send us birth announcements and holiday cards. And many of the parents, as I said, are here today. As a physician, I would like to just specifically address the medical impact of this lack of coverage. As you've heard from many people today, the not having access to care results in a delay in seeking care. People choose ineffective alternative treatments or choose to not access treatment at all. And often by choosing these inappropriate services that may be covered by their insurance, such as surgery or less effective medications, they may end up costing the system more in the long run. And I think we've already heard examples of that. The treatments and care that we are talking about is well-proven and safe medical technology that's been established over the last 40 years. All of it is available in Maine. People often ask, why is it so expensive? It's not one expensive thing. It's a lot of things that add up over a month. And it's just like if you go to the emergency room without health insurance, your bill is $28,000 and you're there for 6 hours. So the healthcare system is not efficient when people don't have coverage for treatment. The proposed legislative document includes coverage for basic testing to make adequate diagnoses, as well as a range of treatments of varying complexity and cost. Again, this is not just about IVF. There are many people that need simple treatments that are not too complicated or expensive on a global level. A small percentage will require more complex treatments such as IVF. By offering infertility insurance coverage, we create a more equitable system so that all of the people that you're hearing about today are able to access care and start their families. I put some other stuff in my written testimony, but I think it's redundant to what people have already said today. So I'd be happy to take questions and respect your time today. Thank you very much.
Thank you very much, Dr. Lannon. Any questions from the committee? Seeing none, we appreciate your cutting your testimony a little short. We do have the written version.
Thank you very much for your time.
Thank you. And next we will turn to Hannah Johnson of Hollis Center.
Hello, can you all hear and see me okay?
Yes, thank you.
All right, great. Good afternoon now. My little write-up said morning, but it's been a long day so far. My name is Hannah Johnson, and as you said, I do reside in Hollis Center, Maine. I encourage you, and know many of your constituents would support and encourage you to vote ought to pass for LD 1539, an act to provide access to fertility care. Access to fertility care is so important in so many ways. The lack thereof has caused severe financial burden and emotional distress in just determining our ability to conceive safely, and now our need for IVF to be able to grow our family. For us, we were able to have our first child successfully. When we tried to welcome a sibling, we suffered an ectopic pregnancy in the middle of a pandemic with severe internal bleeding and subsequent loss of our pregnancy. We chose to then have a procedure done to assess the quality of the last fallopian tube that I had to avoid putting my life at risk again and avoiding that complication. But because that procedure that we had is considered fertility care, it was not covered by insurance. And that's just, it's unfortunate. After hearing our results, we are only able to conceive via IVF. Currently, I work at a large-scale healthcare organization, but we don't have access to affordable fertility care. My husband is self-employed, and I carry my family on my insurance plan. Recently, we've discussed two options: either leaving my career behind and finding a new job in New Hampshire, whatever that may be, that I can commute to, or my husband giving up his dream of running and getting his small business going in Maine, and he do that as well, or we both just plain move and try to figure it out. And sadly, this is happening more and more as Maine is not providing the support that aspiring families need to remain here. I've actually had two friends that have decided, this doesn't work for me, and they have transitioned over to New Hampshire, and that's where we actually got the idea from. For many of us showing our support, the family we desire isn't an option due to financial constraints of fertility care in Maine. And it's so unfortunate that simple diagnostic procedures are not even covered because they can be labeled under the fertility care or infertility with insurance companies. It's just as unfortunate that Maine's families do not have access to fertility treatments to further grow Maine's younger population. I grew up in Maine, left Maine, but I returned because I wanted to grow my family here. And unfortunately, this may no longer be an option for me. I guess I'll leave it at that, but I do want to thank you for hearing and considering my strong stance on this bill.
Thank you very much, Ms. Johnson, for your testimony. Any questions from the committee for Ms. Johnson? Seeing none, we appreciate your telling your story. And we'll ask Brooke Hamilton of South Portland to testify.
Good afternoon, Senator Sanborn, Representative Tepler, and esteemed members of the Hcifs committee. My name is Brooke Hamilton, and I'm a resident of South Portland. I'm testifying today in favor of this bill. I would like to echo all of the sentiments that those before me have shared. I am also the mother of two children who were conceived via in vitro fertilization, or IVF. My husband and I paid 100% out of pocket for all of our fertility treatments. We are incredibly privileged to be able to use savings and home equity, and I certainly understand that all Mainers do not have that option. The median household income in Maine is $59,000, and one round of IVF costs roughly $20,000. For those who have exhausted all other options, the cost of IVF is not only unpalatable, but also unattainable. Couples often take on considerable debt for treatment. Again, we were lucky to have savings and some home equity, but our treatment was north of $60,000 to have our children. I know a couple of these things have been touched on before, but I want to make a couple more points here. That in states with mandated infertility insurance, the rate of multiple births, which is twins and triplets, is lower, which again means fewer high-risk pregnancies and fewer NICU stays. And sometimes, especially with LGBT folks, IVF is the only way to expand their family. It's a stressful, arduous process that takes a financial toll, a physical toll, and emotional toll, as we've heard here today. Women with the infertility diagnosis often have the same levels of anxiety and depression as women diagnosed with cancer. If Maine is to become a more equitable place that attracts, supports, and allows young families to flourish, passing this bill is a great start. Thank you for your time and consideration, and I'm happy to take any questions.
Thank you, Ms. Hamilton. We appreciate your testimony. Any questions from the committee? Seeing none. Once again, thanks for sharing your story. And next we will turn to Jessica Hammond of Rumford.
Hi.
Hi, Ms. Hammond. Welcome.
How are you? Good. So good afternoon. My name is Jessica, and I first want to thank everyone for hearing all of our stories. I live in Rumford, and my daughter is 8 years old. It took her dad 95 years. Lots of tears, prayers, good doctors, and our insurance company, through my husband's employer, which was actually the state of Maine, to understand that infertility is not a choice, to create her through IVF. I cannot imagine if we hadn't had health insurance that did cover a portion of the medical part of our IVF journey. I wouldn't be making her dinner tonight, and I wouldn't be reading her a bedtime story. Unfortunately, after having her, I found out that I had placenta accreta, and I had to have an emergency hysterectomy. Fast forward 8 years, and we desperately want to complete our family. But this time, our current employers, neither of them cover any medical portion of our infertility journey. I have been on both sides of the fence now. It was so much emotionally and physically 8 years ago, and we didn't even have to worry about the financial piece like we are this time. To already have so much stress and just be told to complete our family would cost us an astronomical amount that the average family cannot afford. It's not fair. Everybody should have the opportunity to complete their family. I urge you and ask you to vote yes on LD 1539. It is the first step in beginning to stop attaching shame to infertility in the state of Maine. I appreciate your time in listening to our stories.
Thank you for sharing your story, Ms. Hammond. Any questions from the committee for Ms. Hammond? Seeing none, we appreciate your being with us. And the next person we will hear from is Davina Fankhauser, Fertility Within Reach.
Thank you.
Fankhauser, yes.
Thank you very much, Representative Tembler, Senator Sanborn, and members of the committee. My name is Davina Fankhauser. I am a former fertility patient and have founded a nonprofit organization, Fertility Within Reach. I provide educational tools, resources, and data to aid legislative decision-making. There is a misconception that infertility is predominantly an emotional issue that deserves sympathy. In reality, infertility is a disease and can cause life-threatening illnesses such as ectopic pregnancies. And while more than 90% of fertility healthcare is addressed with medications and/or surgeries, less than 3% require assisted reproductive technology such as in vitro fertilization. And for most, the earlier they access treatment, it reduces the need for assisted reproductive technology. Consistently mandate benefit reviews and actuary studies on similar legislation show the fiscal impact as 1% or less toward the total premium cost of healthcare. These results are in line with the benefit reviews completed in Massachusetts, Connecticut, and Rhode Island, which average $1.39 per member per month. When considering legislation, New Hampshire chose not to order a cost analysis since the rates were consistent throughout New England and the United States. A California fiscal review projected a 10% pent-up utilization rate is expected in the first year of the new benefit, followed by a drop in leveling off of benefits utilized. Insurers will claim higher per member per month rates because they create their own analysis, which includes expenses utilized after the health benefit in question. And please note the dollar amounts you've heard from patients are cash prices, not the negotiated discounted rates between the insurers and the providers, as in the doctors. LD 1539 provides Mainers with the security of insurance coverage resulting in more singleton pregnancies and lower outcome costs. My written testimony details the cost savings. Dr. Alex DeLugi, the National Medical Director for Infertility at Optum, says multiples are more likely to require long stays in the neonatal intensive care unit, which increase costs. It's important for employers and health plans to connect the dots between the cost of infertility benefit and the significant savings on the maternal and neonatal side. I would like to thank you for considering these facts. I respectfully encourage you vote ought to pass and recommend a mandate review for LD 1539. I personally experienced how a lack of benefits led to more than $1 million in healthcare expenses for my self-insured employer, which I am happy to share with you. But your favorable vote on this bill is a legacy that can last for generations. I'm available to answer any questions you have.
Any questions from the committee for Ms. Fankhauser? Seeing none, thank you very much for your testimony. And next we'll turn to Linda Goya. I hope I'm pronouncing that correctly, of Gorham. Welcome.
Good afternoon. Thank you for taking your time to hear all of our stories. My name is Lynn DeJoya. I'm a resident of Gorham and I work for Maine Health. I would like to share with you why I'm in support of this LD 1539. I've been struggling with secondary infertility for over 3.5 years now. Secondary infertility is when someone does have a child but has a difficulty conceiving another child. I have a medical condition called PCOS, polycystic ovary syndrome, that is making conceiving a child naturally next to impossible. In the past few years, my husband and I have gone through 14 rounds of fertility treatments with medications called letrozole and Clomid, with multiple failed attempts at IUI. Each round of medication also comes with monthly office visits, labs, ultrasounds, ovulation or pregnancy tests. All of these expenses are not covered by my health insurance. These last few years have been exhausting mentally, emotionally, and physically for my whole family. I'll never forget the day that my son, who was 8 at the time, and I were shopping at Hannaford. We saw 2 little kids holding hands, walking with their mom, laughing and playing, and he turned to me and said, "Mom, I can't wait till the day that I have a little brother or sister." So there I am in the middle of the produce section with a lump in my throat, trying to hold back my tears so I can try and sound convincing when I tell him, "Don't worry, Dom, that day will come. God will give us a baby when the time is right. We just have to try and be patient." As you can imagine, it's extremely difficult trying to explain to an 8-year-old that you're doing absolutely everything you can to give him a sibling. My OBGYN told me back in November that we can no longer continue to proceed with the treatment plan that I was on. The IVF would be my only option left to have a baby. This was heartbreaking to hear. When we found out that 1 round of IVF would cost her up to $20,000 out of pocket with absolutely no guarantees of success, it was devastating. My husband and I are hardworking Mainers, but we were forced to make the hard decision to having a baby on hold because of this financial burden. I personally feel that fertility treatment should be a right and not a privilege. Thank you for your time and consideration.
Thank you, Ms. DeJoya. Any questions from the committee for Ms. DeJoya? Seeing none, thanks for sharing your story. We appreciate it. And we'll turn next to Ben Carling of Waterboro.
All right, good morning. Can everyone hear me?
Yes, we can.
All right. My name is Ben Carling, proud Navy veteran. I live with my wife, Julie, on 4 beautiful acres in Waterboro. Last October, after trying to conceive for a few years, we got the news that my extremely low sperm count cannot be treated. So IVF is our only option to have kids. Like most Mainers, neither of us have fertility coverage. I'm a federal employee, so my insurance plan goes along with state minimums. My wife works for a small business in Portland, and she had to approach her boss and ask if they would consider changing their insurance plan to cover IVF. It's hard to talk about this with people we love, let alone with your boss. On the opposite side, imagine being that boss and telling your valued employee that you can't cover it because of the small staff and available insurance plans. And we can afford kids, but not IVF. Without insurance coverage, we may not be able to start a family at all. Together, we made over $100,000 in 2020, nearly double the median household income for Maine. But the costs for IVF are insurmountable. Depending on how many embryos we get, 3 rounds, which is the average number for success, 3 rounds of IVF for us would cost between $35,000 and $60,000, somewhere between my wife's annual income and my annual income. We literally need to spend an entire year's salary to get pregnant. And then all the regular expenses of childbirth and parenting afterwards, not to mention if we want to have additional children, which we do. And then all the regular, without insurance, we could just barely cover the low end of that estimate by completely draining our savings, maxing our credit cards, and borrowing from multiple family members. It should not have to come to this. If we can barely afford it, what chance does the rest of Maine have? And speaking of the rest of Maine, because so few people in Maine can afford IVF, Maine only has, well, actually, apparently there's 2 facilities, but I only know the one in South Portland that performs IVF. So if you live north of Bangor, you're completely out of luck, considering you need daily monitoring and such. If this bill gets passed, more clinics are likely to move to Maine, improving the lives of Mainers. We're lucky to be close to Portland, but I'm also outraged that we have to pay exorbitant medical costs just to have a family in Maine, when my friends in Massachusetts and Illinois who've done IVF, while still paying thousands of dollars, mind you, were able to commit to multiple rounds of IVF. Sure, it would be cheaper to get a sperm donor, but when Julie and I fell in love, we started talking about our future together, and Julie said something to me I will never forget. I never thought I wanted to have kids until I thought about having them with you. She wants my kids, not someone else's. And I want it too. I've always wanted to be a father. I grew up believing that God's purpose for me on this earth was to be a good father. And I'm the one with the infertility diagnosis, leading me to feel inadequate, even less of a man. It's painful to see everyone I know with kids when I want that so badly. I want to emphasize how hard this is for me as a man. Fertility is not a woman's issue. It's a family issue, and men are a part of that family. And as multiple members here and others have said, we're going to hear from several women on this issue. I felt invisible. And when I'm the only man signing up for this, I feel invisible. When I'm the only man on the the men's support group for Resolve New England, I feel invisible, just as an aside. One final note, we are a man-woman couple, but fertility costs are a very commonplace experience for same-sex and trans couples as well. Whatever legislation you might draft or approve, I just ask that you please take them into account. Thank you for your time, and I'm open to any questions.
Thank you so much, Mr. Carling. We see you. And I will say that Senator Brenner has a question for you.
I don't have a question, but if you'll indulge me, Madam Chair, I have a comment.
Please.
Mr. Carling, I just wanted to apologize for not including you in the beginning of my testimony, and I appreciate your words, and we hear you.
Thank you.
Yes, we do. Yes, thank you so much, Mr. Carling. We are glad that this is not just a women's issue, and believe you. Thank you. And last but definitely not least on my list is Jill Barkley Roy. Please join us.
Hello. Hello, Senator Sanborn, Representative Tepler, and other members of the committee. Thank you so much for allowing me some time to share my testimony in support of this bill. I don't want to be redundant. I submitted some written testimony that talks about the costs associated with my own journey. But I will just say that, you know, if anyone is listening to this, I want you to think about whether or not you wanted to be a parent. And if the answer is yes, how much you're willing to pay for that. For me, the answer to the first question has always been yes. The answer to the second question is over $40,000. My wife, Amy, and I are happily married. We live in a beautiful home in South Portland with our golden retriever, Winston. Our families are fully supportive of us, and we have a large circle of incredible friends here in Maine and across the country. Our jobs are fulfilling and provide a comfortable life for us and medical insurance. By all definitions, we are incredibly privileged. But when we began our journey to become moms, we knew it would be a tough road. And our doctor recommended that we try to get and stay pregnant with in vitro fertilization, or IVF, which you have heard the price tag is astronomical. We had insurance at the very beginning. My health insurance changed, so we had to change plans and take out a sizable personal loan for our first cycle of $20,000. And when that cycle failed, we found ourselves devastated once again because we could not afford to pay for another round out of pocket. I worked with my employer to find a solution for providing coverage for IVF. And we had some coverage to do one more cycle, which we started in February of this year. And it sadly ended in a miscarriage. We didn't know if we could emotionally afford another cycle, but we did know that we could not afford it financially. At this time, Amy and I are on a different path toward parenthood. It's been really complicated to arrive at this decision, but we know that we're supposed to be moms and co-parent together. And we know that our end result will be more beautiful than we can imagine at this particular moment. I'm not here today because I'm not at peace with my decision on how I would become a parent. I'm here today because there were financial barriers that made arriving at this decision more complicated and painful than it needed to be. If I had insurance coverage, we could have continued on our path of parenthood through IVF after our first failed cycle with no gaps. We could have made a decision to stop trying based on knowing we had given it our all and on the medical advice of our doctor. We would not have to consider our finances, a second mortgage, or incredible amounts of debt as part of that process. And I wouldn't be here today still wondering what if. What if I could have become and stayed pregnant and given birth to a biological child who looks like my late sister or other beloved members of my family? This bill would give Maine women and families options to choose how to become parents, including families like mine. I'm so thankful it's been introduced. I know so many important issues come across your desk, and that this one is so personal for so many Maine families. So thank you for taking time to hear and consider my testimony, and I urge you to support this bill.
Thank you very much, Ms. Roy. Yes, I muted, I'm sorry. We really appreciate your testimony, and we'll ask the committee members if they have any questions. Seeing none, it's nice to see you. And good luck on your parenthood journey with your wife.
Thank you.
And I will turn back to my list because having refreshed my page, I see a few more people have requested to testify in favor. So next I will call Lisa Hopper of Portland.
Can you hear me?
Yes, we can.
Okay, sorry for the late submission. I just found out that this was happening, so I threw something together last minute. My name's Lisa. I'm a resident of Portland. I'm here today to express my support for IVF. Now, I know you've heard from a lot of people today, and with good reason, as they can't have children without the help of IVF. But you have found out today that there's many families that cannot, sorry, my thing exited out. So now I lost my thing that I sent in. So I'm gonna talk from my heart is what's gonna happen, which is gonna be harder, but it's okay. So Me and my husband have been together for 11 years. And last year we decided it was time to make a family. And in finding that out, we found out we were both carriers for cystic fibrosis. I don't know if any of you know about cystic fibrosis, but it affects 30,000 Americans worldwide. It's a rare condition, but it affects a lot of people in Maine as well. When finding this out, we went to a genetic counselor, and she told us that we had a couple options. One of them being, in order to have a child without it, 100% sure it would not have cystic fibrosis, that we would have to do IVF and pay over $35,000. Now, this was not a cost that, we could afford at the time. We didn't know that we were ever going to have to do this. So we made an extremely hard decision to not have IVF. In December 21st of 2020, we gave birth to my son, Frankie, who does have cystic fibrosis. So he had a 25% chance of getting it, 1 in 4, and he did get it. This was very hard for us. We did reach out to insurance companies before to see if they would cover it, and they said no. Now, with Frankie having cystic fibrosis, he will need treatment for the rest of his life, which under my health insurance, I work for Maine Med. I have pretty good health insurance. I'm a nurse there. The cost for the insurance company is going to be way more for all of his treatment than it would cost for IVF. I am in complete support for this fertility coverage for the state of Maine for many families. Thank you.
Thank you very much, Ms. Hopper. That actually worked out just fine from your part. There was no problem with that.
Thank you
for sharing your story with us. Any questions from the committee for Ms. Hopper? Seeing none, we appreciate your being here. And I'll turn to the attendee list. I see someone has their hand up. Michelle Wells, yes, who had wanted to testify on this bill, but was signed up accidentally for another. Thank you for reminding me, Ms. Wells. Please join us.
Thank you. I am one of the people who were filed under the wrong bill. So thanks for adding me on right at the end. I know it's been a long day. My name is Michelle Wells. I live in Saco, Maine. I'm here in support of LD 1539. I'm actually from away, being from Ohio, and my husband is also from away as well. I've been living in Maine for 10 years, and we both chose this beautiful state to live and raise a family. I'm someone who has already suffered through the throes of fertility treatments due to 2 different diseases of my reproductive system. We've had 3 miscarriages, 2 of these being ectopic pregnancies that have been mentioned already. This resulted in emergency surgeries to remove both the pregnancies as well as essential parts of my reproductive system, which led me no choice but to turn to IVF. Due to lack of healthcare coverage to aid in the functioning of my reproductive system, my husband and I have spent $25,000 plus interest to have our son, who is now 17 months old, and the first Mainer of our family. We used a home equity line of credit, cleared out savings multiple times. My dad borrowed money from his retirement, and we were gifted money from my in-laws to cover just our one child, who was totally worth it. We're privileged with this access, and not all Mainers are, as you've already heard. It's confusing to us that healthcare isn't required to cover these treatments, as all other health conditions do require coverage for treatments. And I understand that Maine state employees are offered some partial coverage for fertility treatments, but Maine residents are not. Having siblings can be a blessing. I'm one of 4 girls. We sadly lost our oldest sister to cancer when I was 16. My husband is one of 4 boys. Siblings have brought an expansion to life to us that is hard to put into words. Our families grow together. We experience loss together. We experience joys, stages of life, offer support and understanding that others can't because they haven't lived this shared experience. We may outlive our parents together, but we will have each other. We want this for our son, Asher, too. Our only chance of bringing him a sibling is to continue with IVF again. However, we have to be ready to spend a minimum of $5,000 just to transfer one single embryo. And it has crossed our mind, do we transfer 2 just for potentially increasing our chances of a pregnancy? If that doesn't work, like our very first transfer didn't work, we have to be ready to spend it again. This financial burden will likely put us into debt again before we ever even get the chance to parent a second child. It might also make us decide to not move forward with having a second child. And I did have some information about, our job seeking outside of Maine, but it seems like that point has been made, and that also resonates with our family. I've included a written testimony that will share many more details of our experience. And so I just ask that you support this bill, as it will help countless other young Mainers who want to live and raise their family in Maine who are facing infertility. Thank you.
Thank you, Ms. Wells, and thank you for your patience with us today, since your testimony was misfiled. And you hung in there, and we appreciate it. Any questions from the committee for Ms. Wells? Seeing none, we do thank you for your testimony, and I will now turn to the attendees on the Zoom call again and ask if there is anyone else who wishes to testify in favor of 1539. Seeing none, I will turn to those speaking against the bill and invite Ms. Pelletreau to join us.
You did have a late hand for somebody that was registered in support.
Oh, I'm sorry. Thank you. Yes, Christian, could you transfer Ms. Evans over? Ms. Evans?
Hello. Can you hear me?
We can hear you. And if you have video, please turn it on. If not, that's fine.
Oh, it looks like the video is not working.
That's fine. Please just go ahead.
Sure. I just wanted to add to the many other voices of support for this bill. I am in a same-sex couple. My wife and I married 3 years ago, and I found the person I wanted to have children with later in life, like so many of us nowadays. And that cooing that you hear is my daughter Franny. She was conceived through IVF after a string of failed IUIs. And she is the absolute light of both of our lives, and we feel such a well of gratitude for the chance to start a family. But my heart breaks for all of the people who have come before me that have suffered so much on this journey. And my friend Lisa, who just spoke, people should not have to make these decisions. They should not have to be put in the situation where they need to gamble with their health, with their children's health. It just does not make any sense that this is not covered. Starting a family is just so fundamental to the human experience, and it should really be supported. So I just wanted to encourage you to vote for the passage of this bill, so that people like me and people less fortunate than I am who couldn't afford IVF will have the opportunity to grow a family and to enrich the state at the same time. So thank you very much.
Thank you, Ms. Evans. Your daughter certainly has a nice, strong voice. And are there any questions on the committee for Ms. Evans? Seeing none, thank you for telling your story, and we'll turn back to Ms. Pelletreau, who will be testifying in opposition to the bill.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here with the task of testifying in opposition to this bill before you today. Just a little bit of background. For those of you who may not be aware, Maine has seen similar mandates for fertility many times in the past, and no past legislature has decided to move ahead with them. Now, you may decide to move ahead with this one, in which case we would advise you to have the Bureau of Insurance do a mandate study. I will offer a few other points on this particular bill. One of the things that's significant about this bill is that it has infertility treatment, but also fertility preservation. So you've heard a lot from proponents about treatment for infertility, but also this notion of preservation, which is a little bit newer concept. And what it is or I guess what is standard for fertility preservation in places that do it are sperm banking for men and egg or embryo freezing for women. The costs for freezing an embryo in 2018, this is from the National Academy of State Health Policy, their piece saw that the annual cost was $10,000 for that. So that's important, that this is a fairly broad mandate. If you did decide to go forward, you might consider doing something narrower than what has been proposed. So, for example, some states have offered or have required that coverage be offered. Some states, I think including New Hampshire, have limited the markets to which they apply the mandate. So in New Hampshire, it does not apply to the individual market. Some states have limited their mandates to those facing iatrogenic infertility, which is infertility caused by a necessary medical intervention. I think there are 9 states. I just found something from the National Conference of State Legislatures that reviews the mandates in each state that exist. So I think there definitely are some. It's also definitely not the majority of states. But, more states are coming online all the time. And I believe it's about 9 now. But of those, particularly the ones in New England, do not include coverage for elective fertility preservation, so that egg freezing, for example, due to natural aging. They don't cover infertility treatments that might be needed after cancer treatment to achieve a pregnancy, but in those cases only for the preservation. And they don't cover long-term storage costs. I believe that this bill calls for 5 years storage cost coverage. So those are some thoughts for the committee to consider. Thank you.
Thank you, Ms. Pelletreau. Any questions from, yes, Senator Sanborn, please go ahead.
Thanks. Ms. Pelletreau, I have kind of a wonky question for you, which is, I know that some of your members do business in the New England states that have these mandates and haven't looked closely at the language of our bill. But I know that there's a principle of sort of exhaustion of assisted reproductive technology before going on to sort of advanced assistive reproductive technology. We did hear from at least 1 or 2 folks today who were sort of choosing not to do sort of sperm implantation, sort of, I don't know what the right word is, IUI, I think is the right term, as opposed to IVF, because then the parentage would be different of the resulting child. My understanding is that plan design is often that you have to go through sort of a stepped process and you can't skip over a step. So I would be curious if you could look at the mandates around New England and how they're implemented with your plans to let us know about that issue of exhaustion and not being able to skip over either. I think like ovulation treatment and IUI are the sort of sometimes prerequisites for being allowed to access IVF. And so I'm curious about how that works kind of down in the weeds. We've heard a lot of moving stories today, and I want to make sure I understand whether we're really helping folks or not. And also how the stepped process applies in circumstances with same-sex couples.
Mhm.
Thank you.
Sure.
And I think I'll follow up Senator Sanborn's question with a question about whether there is any special coverage in particular for post-cancer treatment for people of childbearing age. Because I think that the storage options often apply to those folks in particular.
Mm-hmm. I think that's true, especially for people who have cancer treatment that directly impacts their reproductive system.
Yes. Any other questions from the committee for Ms. Pelletreau? Seeing none, thanks for your testimony. And turn to, if she's back, Ms. Ossenfort, and if she's not, Mr. Garrity speaking for Ms. Ossenfort. You're here.
I am Representative. Senator Sanborn, Representative Tepler, and members of the committee. My name is Bruce Garrity. Again, I'm testifying on behalf of Anthem. In place of Ms. Ossenfort, I have made note of the questions that have been asked, and I will forward those. I would like to make a couple of points in addition to those that were made by Ms. Pelletreau. First, the language of the bill says that coverage, quote, be provided to the same extent that coverage is provided for other medical services or prescription drugs, and that carriers can impose co-payments, co-insurance, or maximum benefits different from those imposed on coverage for other services. Ms. Ossenfort wanted to point out that it's not clear how this could or would be implemented, since cost sharing and maximum benefits can vary by type of service. So I think that's something the committee would have to address should it decide to move forward with the bill. The second point specific to the bill that we've been asked to raise is that we think the legislation essentially requires unlimited coverage by specifically limiting or prohibiting limitations based on, quote, arbitrary, I think that's the word in the statute, factors such as age, number of conception attempts, or dollar amounts. This is very broad-based and obviously would have significant implications as the committee moves forward with this bill in terms of overall costs. But let me add one other point that was not Ms. Ossenfort's, but I think is pertinent in terms of history. You've heard from Ms. Pelletreau that this is not the first time this bill has been presented. I actually testified on the first time when it was offered by then Senator Robert Murray. He went on to become the commissioner of the department and thereafter a Superior Court judge. And we heard very moving testimony from supporters of the bill at that time. And the committee chose not to move forward with the bill as it has in other instances. Of course, circumstances change, times change, and perceptions and views of what's necessary change. But I do think this is an important one to keep in mind as you balance cost versus need or appropriateness, that this has been looked at any number of times going back to the mid-1980s, the first time I'm aware that it came up. And with that, Representative Tepler, I'd be happy to try and answer any questions the committee might have.
Are there any questions from the committee for Mr. Garrity? I have a brief question, Mr. Garrity. The last time this came up, did Massachusetts and New Hampshire have access to fertility treatment?
I don't know the answer to that question.
Yes. Okay, because I think that's an important.
I will. I'll try to get that answer for you, Representative.
Thank you. Any other questions? Seeing none, is there anyone else in the attendee list who wishes to testify in opposition to the bill? Seeing none, I'm going to turn to those testifying neither for nor against and ask Ms. Cook into the panel. Welcome back, Ms. Cook.
Thank you. Good afternoon, Senator Sanborn and Representative Tepler and members of the committee. I'm Kim Cook. I'm here on behalf of Community Health Options, testifying neither for nor against LD 1539. So thank you for having me again. I'll try to be quite brief and simply say that Community Health Options understands and has compassion for those in need of the services that this bill would require, and note that whether coverage of these services should be required is really a matter of public policy, as you well know, which is why it's before your committee. But urge the committee that if you are interested in requiring the coverage, we would ask that you do go forward with a mandate study to understand the fully understand the impacts of what would be covered and how that compares with other states' coverage, but also the impacts to premiums. So as you know, from your work on these issues, mandating health benefits that go above and beyond the essential health benefits increases the health insurance premiums in the fully insured market. And these premium increases are not covered by the advanced premium tax credits, or APTC, otherwise known as subsidies. So hence, even the consumers who receive subsidies for their health insurance premiums on the individual market pay for the cost of these additional benefits. So we just want to mention that because to keep in mind that for those who would otherwise be paying a $0 premium or very low premiums, each time we do have a mandate that goes above and beyond essential health benefits under the Affordable Care Act, the APTC does not cover that, and so those folks then pay that amount in their premium. And so we've had a few of those go through, I think, over the last few years, and I don't know what they add up to, but I think it would be worth you looking, looking at that as part of the mandate study. And I'd be happy to answer any questions you might have. Thank you.
Any questions for Ms. Cook from the committee? Seeing none, thank you for your testimony. Oh, I'm sorry, Rep. Barford has a question.
Yeah, I'm sorry I was late to the draw on that one. I apologize. But thank you, Madam Chair, and thank you for being here with us, Ms. Cook. I've been wondering about this, and finally I'm spitting it out. Who determines the charges? When we've been hearing a lot of figures in the testimonies today. Are those charge amounts and those negotiated rates? They're very large numbers, and I'm just wondering how these numbers are arrived at, if you have any understanding of that.
Representative Arford, when you say charges, do you mean the cost that providers charge.
One woman mentioned that retrieval of one egg costs $5,000, for instance.
You know, I would not even pretend to venture a guess. I think that is really a matter, at the end of the day, these are providers' charges. So it's the charge that the provider has, because right now these are services that are not covered under health insurance, or under some health insurance at least. It really has to do with the charge that the providers are charging to the patients. It's sort of that direct. There's no third party payer in those circumstances. So I don't know how those are arrived at, or the basis for them, but the provider community might be able to better answer that.
Thank you.
Okay, thank you, Ms. Cook. And I'll just take a last look around and see if anyone else has a question. Seeing none, I will ask if there's anyone else on the Zoom who wishes to testify on LD 1539 before we close the hearing on this bill. Seeing none, we will close the hearing on LD 59. And frankly, some of us have been at our computer screens for 6 hours already today. And so we are going to take a break. I think at least half an hour. We still have, I think it's 3 bills left to hear today. And is it 3 or 4?
It's 5, I think.
4, 5. Okay, we still have a lot of work left to do in any case. So let's keep it to half an hour, and we'll be back here for this meeting at 2:45. That's actually slightly less than a half an hour break for us. Hopefully we'll get through the rest of our work before too late this evening. So thanks everyone who testified so far, and we'll be back at 2:45. Hello. Committee members, please come back. We can get started again now. Please turn on your video at least for a moment so I know you're there. Thanks, Representative Melorano. Is anyone up? Representative Morris? I need a few more folks to join us. Representative Evans, are you there? Representative Blyer? There he is, okay. Representative Arford? Representative Brooks? Great. Oh, there's Representative Blyer. Okay, we have enough folks to get started. And we are going to open a hearing on LD 922, an act to help cancer patients with fertility preservation. And I guess this is our sponsor who's just joined us. How are you, Representative Craven?
I am still here, just like you are.
Yes.
What an eventful day. Thank you. Thank you for all your work. And I really appreciate it. And thank you for having me here today. So Senator Sanborn, Representative Tepler, and esteemed members of Health Coverage Insurance and Financial Services Committee. My name is Margaret Craven, and I represent House District 59, which is part of Lewiston. And I'm pleased to be here today to introduce LD 922, an act to help cancer patients with fertility preservation. This legislation would require insurance carriers to provide coverage for fertility preservation services when cancer treatment may directly or indirectly cause infertility. We know that chemotherapy, for example, can damage cells and reproductive organs. We also know that fertility treatments are quite expensive. Many health care plans do not cover fertility services, and while there are some that do, the legislation would allow cancer patients to take proactive action to preserve their ability to have a family before they risk becoming infertile due to cancer treatments. The National Cancer Institute estimates that 4.6% of all new cases of cancer in 2021 will occur in adolescents and young adults between the ages of 15 and 39. Further, according to this Surveillance Epidemiology and End Results SEER program, they also find that 5-year interval rates for this group is 85%. I shared these statistics with you because while young people do get diagnosed with cancer, they have a very high likelihood of surviving and carrying on with their lives. The bill before you is a positive step to help young Mainers continue on with their lives after cancer. I also want to note that Maine would not be the first state to take this proactive step. According to Team Up Cancer, similar legislation has been introduced and passed in 10 states, including New Hampshire, Colorado, Illinois, Maryland, and Connecticut. Thank you very much, and I'd be happy to answer any questions.
Thank you very much, Representative Craven. Are there any questions from the committee for Representative Craven?
So I know that you heard a similar bill earlier today that I am a co-signer on as well. And am very happy and willing for you to fold this into that bill if you would like to do that. I think that the outcome, there is a religious exemption in my bill that I just feel is not as inclusive as Representative Madigan's bill. And so I would just put that out there.
Thank you very much, Representative Craven. Any other well, that wasn't a question, but thank you. Any other questions in the committee? Seeing none, we appreciate you bringing us this bill. And we'll turn to testimony in favor of the bill and welcome Hillary Schneider of the American Cancer Society Cancer Action Network.
I do not see Hillary Schneider on the call right now.
Okay, well, Ms. Schneider obviously left us some written testimony, so I'll assume she just, I think when she delivered her testimony earlier, she said it was for both bills, actually. So that must be the reason there. So I will invite someone who's been waiting patiently since this morning, Rico Dentz from Hartford, to please join us. Mr. Dentz?
Oh, sorry, I didn't realize I had to click unmute. I know you all have had a long day, and I thank you for taking the time to hear this bill. I am also in favor of combining the bills, whatever, to help make the bills pass. That is definitely important. I'm a cancer survivor. I'm a young adult cancer survivor. I've lived out of my car and traveled the US speaking to legislators to help other young adult cancer survivors. I've attended many cancer conferences of young adults and hearing countless of testimonies of seeing women just tearing up and sharing their testimony that I had to have a choice of either getting treatment or trying to fundraise the money to be able to freeze their eggs. And it is really hard. And I share my testimony. I more want to, the cost is not that much compared to thinking about once they're eligible for fertility treatment after they've already gone through the chemotherapy, but now it could be damage that they could never have kids. But it's not about just having the kid, because here you have the beauty of being able to have a child being born. But like, let's say you can't have one. Now think about your sister or your brother. You see them having kids. You are reminded that I can't have one. Then you see them, first day of school, they're talking about the first day of school, thinking about even birthdays, birthday parties, people like, imagine the woman, she's like, someone asked her who just knows her, hey, are you going to be having kids? I see you're married. Then thinking about when like their siblings, their kids graduate from high school, they graduate from college. There's so many memories that a person who, by passing this legislation and or the other legislation, I think it's the 1539, will make it possible that people get to have these wonderful full memories of seeing kids growing up. and then having grandchildren and getting time to spend with grandchildren. So it's not just a short-term thing, it's a long-term issue that people are constantly reminded about. And I wanted to keep it short, and that was it.
Thank you very much, Mr. Denson. We appreciate your waiting and delivering your testimony to us. Is there anyone on the committee with a question for Mr. Dents? Seeing none, we appreciate your testimony. And now I'll turn again to the attendee in our Zoom call and ask if there's anyone else wishing to testify in favor of the bill. Okay, seeing none, I'll turn to those in opposition and we'll ask Ms. Peltro to come back again.
Good afternoon. Representative Tepler, Senator Sanborn. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify in opposition to this bill. I won't belabor it. I think we spent a lot of time talking about fertility and fertility preservation in the preceding bill. I'm happy to answer any questions, but our arguments are along a similar line.
Thank you, Ms. Peltro. Any questions from the committee for Ms. Peltro? Seeing none, thanks for your testimony. And I still don't see Ms. Ossenfort in the room. She has not yet submitted written testimony. I guess we can bring Mr. Garrity in again, although I suspect he's just going to tell us that Ms. Ossenfort will submit written testimony later. Hi, Mr. Garrity.
Hi, Representative. As I was being brought in, the last word I heard was "although," which suggested to me you were not looking for my detailed 11-page oral testimony. Accordingly, I will just say we are in opposition for the various reasons that you have already heard. Ms. Ossenfort will be presenting written testimony, and with that, I'd try to answer any questions the committee might have.
What I actually said was, although I think he's just going to tell us Ms. Ossenfort will submit written testimony. So that was the end of the sentence.
You're prescient.
Yes, I certainly am. Are there any questions from the committee for Mr. Garrity?
Thank you.
So thank you for your testimony. Is there anyone else in the Zoom call who would like to offer testimony on this bill? Seeing none, I'll close the hearing on LD 922. The work session will be seen shortly, will be announced shortly, sorry. And I'm trying to do two things at once. And I'm going to turn things over to Senator Sanborn at this point to open the next hearing.
The next hearing is on my bill, though, Representative Tepler. So that's what you meant by yours. It is mine. It's my bill. You have to keep chairing, unfortunately.
I didn't understand that. I was trying to decipher that. Okay, so the next bill is
I think it's 794.
794, yes.
Okay.
794, an act to maintain Maine's system of therapeutic foster care for children through the creation of a nonprofit risk indemnification trust. And please go ahead, Senator Sanborn, and introduce your bill.
Thank you, Representative Tepler and colleagues. I am Heather Sanborn, as you know, and I am here to present this concept draft regarding insurance for Maine's therapeutic foster care system. Therapeutic foster care is focused on the care of children with developmental, emotional, and/or medical disabilities who are in state custody. Families that provide this level of care are trained by the Office of Child and Family Services to be licensed resource parents. Beginning in the fall of 2020, agencies who have been contracted by OCFS to provide the training and support for therapeutic foster families began to receive renewal statements from their companies for their company liability insurance. Noted on these statements was the fact that they were being increased across each of the agencies by double and triple amounts tied directly to their operation of therapeutic foster care programs. The dramatic increase in rates appears to be due in part to new look-back window laws enacted in many states throughout the country that seek to give adult victims of childhood sexual abuse a stronger voice and an opportunity to file civil claims against alleged abusers, and their enabling institutions by eliminating the statute of limitations on such claims. In an understandable business response, insurance companies have responded by recalculating the risks involved in covering therapeutic foster care programs. Those insurers may be looking toward changes in coverage options for other services as well. If liability insurance becomes unavailable to these agencies, they may be forced to end their therapeutic foster care programs, leaving a gap in our state's ability to provide services for the most vulnerable children under its care. The concept draft anticipates drafting a resolve directing the Bureau of Insurance and the Department of Health and Human Services to develop a state nonprofit risk indemnification trust to serve as a backstop insurer of last resort to provide liability coverage for state contracted providers of therapeutic foster care that are unable to obtain affordable liability coverage through ordinary means. However, I believe that additional stakeholder process and discussions would be beneficial before we jump to the insurer of last resort option. So I would propose that this committee carry over the bill and draft a letter asking the Bureau of Insurance to convene a working group of interested stakeholders, including therapeutic foster care providers, the OCFS, commercial insurers, and others as needed, to evaluate the extent of the problem and participate in crafting a suggested course of action. I suggest that our letter request that the working group bring its recommendations back to this committee by January 1st, 2022 to be reviewed. Thank you for your time, and I'd be happy to try and answer any questions that you may have.
Questions from the committee for Senator Sanborn?
I will just note, because the Bureau or the department isn't going to testify, the Department of Health and Human Services, I don't think is going to testify verbally, that they have let me know that they're open to discussions led by the Bureau of Insurance and with the stakeholders over the interim.
There is written testimony submitted by Todd Landry of Child and Family Services, but there is, as far as I can see, no one on the call to testify in person.
And not what his testimony says. So that's not what his written testimony says, but or Molly Bogart responded to my emails today with a favorable view on us carrying the bill over.
Okay, thank you. All right, so we will now turn to Ms. Shaughnessy for testimony in support of the bill.
Hello, did I make it through?
You did.
Okay.
A wormhole.
Weird moment of spinning. Thank you. Good afternoon, Representative Tepler and Senator Sanborn, members of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is Mallory Shaughnessy, resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. And this testimony is on behalf of the Alliance in support of LD 794. This bill came forth as a concept draft to begin the discussion about a growing concern, as you heard, within the field of child behavioral health and child welfare. Agencies that contract with DHHS to recruit, train, and support families to provide therapeutic foster care within the child welfare system had a rude awakening when the time came to renew their liability insurance this past year. The cost in many cases doubled or tripled. Some agencies were actually told that they didn't think that they would cover them for any more on liability after this year. So it may be completely just ending in some cases. And this is happening across the country, but it is unsustainable to continue this service. At least one agency has completely dropped this service rather than renew their liability. Others are holding on to see if we can work out some kind of response to help cover these increased costs, such as a risk indemnification trust or a pass-through payment or some other solution. Without a fix, we will potentially lose this critical service in Maine, or the state would have to adopt it within themselves. So the Office of Child and Family Services partners with several agencies that provide this support to therapeutic foster resource parents. It's Woodford's Family Services, Community Care, Spurwink, Community Health and Counseling, Kids Peace, Rustic Mental Health Center, and I have spoken to these providers. They are waiting to see if a resolution can let them continue with this service or not. They really are on tenterhooks, wanting to see what's going to happen. We really appreciate Senator Sanborn bringing this issue forward and hope to work with the department, some aspect of the department, whether that's insurance or Office of Child and Family Services or both, to try to come up with an innovative way to address this problem. So we thank you for your consideration of this very important issue, and we're looking forward to working more with them to see what we can come up with. And I'd be happy to bring any other information back to you that you may need.
Thank you, Ms. Shaughnessy. Are there any questions in the committee or any requests for information that we may need to determine how we should carry this bill over? Seeing none, thank you very much for your testimony. And I have no one else signed up to testify. Is there anyone in the Zoom call on the attendees list who would like to testify on this bill? Seeing none, that will bring to a close the hearing on LD 794. And now I will turn the gavel back over to Senator Sanborn.
I will accept it ever so briefly because the bill after this coming one is also mine. But the next bill that we will hear is LD 1614, an act to mandate that certain healthcare providers disclose an estimate of charges at the time of service. A pretty recently referenced bill, so it didn't have a hearing at the same time that we heard some other bills on the same topic. We'll invite the sponsor to join us. And Representative Lookner, you can go ahead.
Thank you, Madam Chair, and my personal senator. So thanks for having me. Senator Sanborn, Representative Tepler, and honorable colleagues on the Committee of Health Coverage, Insurance, and Financial Services. My name is Grayson Lookner, and I represent the neighborhoods of Libbytown, Nason's Corner, Rosemont, and Stroudwater in Portland. And I'm here to introduce LD 1614, an act to mandate that certain healthcare providers disclose an estimate of charges at time of service. I will admit that when I submitted this bill for consideration, it was done so out of equal parts exasperation, narrow self-interest, and spite. During the fall, I went to get a test for COVID-19 after listening to assurances that all such testing would be free of charge, a promise that I suspected at the time would be too good to be true, and lo and behold, I was correct. I received a bill several weeks later for a little over $150. And in that moment, it struck me that there was something inherently unjust and deceitful about medical providers not being required to tell their patients that there would be charges associated with services provided. So I submitted this bill. Little did I know I was just scratching the surface on a fundamental issue with our healthcare system not just in Maine, but around the whole country, a lack of transparency in pricing. I'm not the only person who has experienced such unwelcome surprise bills when it comes to our healthcare. Medical debt is the leading cause of bankruptcy in the United States, and nearly a quarter of Americans have skipped routine checkups or delayed necessary care out of fear of the bills. That is a higher number for younger people. So bad is this problem that it prompted the previous Republican presidential administration, which enacted very few policies with which I agreed, to issue an executive order last year to mandate that hospitals disclose the prices of at least 300 unknown or otherwise called shoppable services that they negotiate with insurance companies. And I think Maine should build on this start. Healthcare is the only industry in which providers are not required to give customers an estimate of charges at the time a service is rendered. If I ordered a sandwich from a restaurant without knowing the price and received a bill a week later for hundreds or thousands of dollars, I would never patronize that establishment again. If I hired a contractor to put a roof on my house without having a rough idea of the charges and found out later that I was being charged an amount equal to the entire value of the property, I would not pay without being forced to do so by court. Even mechanics, most of whom are good and honest trades workers who may discover unknown problems with a vehicle when working on an unrelated issue, usually disclose to customers a ballpark figure of how much servicing that vehicle will cost. If they didn't, they'd probably end up out of business. The major difference between these businesses and healthcare is that in healthcare, customers are referred to as patients and usually don't have the choice to shop around to get the best price. Some economists refer to this as inelastic demand, and it leaves consumers vulnerable to the predations of secretive insurance company and corporate healthcare backroom dealings that are not intended to provide better healthcare to patients, but to increase profit for these individuals. Some things have changed since that fateful day last fall when I received that medical bill and submitted a request for this legislative one. Notably, the passage of LD1, the COVID-19 Patient Bill of Rights, which ensured that nobody in the state of Maine would be charged like I was for a simple COVID-19 test, and that medical and Medicare and Medicaid services are now requiring hospitals to post standard charges publicly in accordance with the previous executive order. Insurance companies and major hospitals have exercised too much power in healthcare pricing without bringing patients into the equation. Our legislature should take advantage of changing conditions and act now to increase transparency in healthcare and reduce surprise billing. Perhaps this bill needs some amending and could be thought of as a vehicle for specific changes that are needed in Maine, in addition to the ones that are outlined in the bill language. I've been made aware that, obviously other bills have been heard to this effect, and, there are rules that are federal rules that will be enacted by next year. So I understand the context, and I still think it's a good time for this legislature to look at that, because that's all available online, what those rules propose, and we can get out in front of it and have parity in the state. So thank you for hearing my testimony, and I'll do my best to answer any questions.
Thank you, Representative Lookner. Are there any questions for Representative Lookner? All right, seeing none, we thank you for bringing us this bill. And just need to reload my list here, make sure nobody else has signed up to testify. If there's anyone in the meeting who intended to testify on this bill, please raise your electronic hand at this time. All right, seeing no hands go up, I will close the hearing on LD 1614 and hand the gavel back over to Representative Tepler.
Thank you very much, Senator Sanborn. And with that, we will open a hearing on LD 1563, an act regarding travel insurance in the Maine Insurance Code. Please introduce your bill, Senator Sanborn.
Thank you, Representative Tepler, and I did not do written testimony for this, but Mr. Garrity will come behind me to explain more about this bill, which is an act regarding travel insurance in the Maine Insurance Code. This is one of those stranded COVID bills that we fully passed, excuse me, through this committee unanimously to pass as amended. Last year, it was LD 2143, and then it died when we did not come back into session. It is a model piece of legislation that's been promulgated, and then we did make some changes from the NAIC model that the Bureau and the United States Travel Insurance Association mutually agreed to last year. This legislation has consumer protections. It's limited lines insurance, not unlike the self-storage bill that we dealt with a short time ago. And so with that, I would ask you to defer any questions to Mr. Garrity, and that's it. I'll urge you to ought to pass.
Thank you, Senator Sanborn. I do note for the committee that there is written testimony from Mr. Allen of the Department from Maine Revenue Services, which has a few concerns with references and language in the bill that I think will be fairly easily dealt with if the committee decides to move forward. But I also see that Representative Evans has a question. Go ahead, Representative Evans.
Just quick questions, Senator Sanborn. This is just building on what we already have, something already in place. You said that it had been worked on before.
So this is a bill that we passed through our committee, but it never became law because we adjourned before it got to the floor. So this is a repeat. It's not building on a statute we already passed so much as redoing the committee work that we already did last year.
Thanks.
Yes, in the 129th legislature, this committee voted this bill, I think unanimously, ought to pass. But it never made it to the floor because of the COVID adjournment. So that is the story. And next we will call Mr. Garrity to testify in favor of the bill. He's submitted 2 pieces of written testimony also. I don't know if they're the same or different. Welcome, Mr. Garrity. Mr. Garrity, you submitted 2 written pieces of testimony. Are they different or the same?
You know, I pardon me, I noticed that just a little while ago, and I suspect they're the same. I don't think that I would have had 2 totally different thoughts that I would have presented to the committee. So I think it's probably the same. I hope it is. Let me start, Senator Sanborn, Representative Tepler, and members of the committee. My name is Bruce Garrity. I'm here on behalf of United States Travel Insurance Services, which is an organization whose members include insurers, managing general agents, insurance producers, and those involved in the travel insurance industry. I know that you've had a very long day, so I'll try not to go on at great length. The NAIC developed a model bill earlier in the 2000s, 2015, 2016, I can't remember exactly. And while travel insurance has been regulated for a long time, generally in Maine, this provided a specific vehicle that was based on the NAIC model. USTIA and the Bureau worked together last session on LD 2143 and presented a unified bill for the committee's consideration. This bill was unanimously supported by the committee. There were no opponents. What this basically does is several different things. It puts in place some clarifications on the responsibilities of producers, managing general agents, and insurers. It clarifies that generally this coverage is considered an inland marine coverage, although it does have health aspects, so at times it can also be regulated as health coverage. It clarifies that rate and form filings have to be made in relation to travel insurance. It also has a number of consumer protections. Those include making this limited line subject to the trade practices and fraud provision of the insurance code, which is chapter 23. It prohibits opt-out clauses in the coverage. It puts in marketing requirements which relate to the kinds of materials that individuals who want to purchase this insurance receive. It has an automatic opt-out right if the materials are submitted in writing through the mail, and it has an automatic opt-out of 10 days if the materials are submitted directly to the purchaser. In short, what this bill does is provide increased protections for consumers, and it provides protections for or clarifications as to the coverage. The primary coverage generally is for things like lost baggage, cancellations, and for health-related problems that occur essentially incidental to or as part of a flight or a trip. I note that the Bureau of Taxation did comment. One of the things this bill has done is clarify premium tax considerations, and we certainly can deal with the points that have been raised by taxation. And I know the Bureau has one other suggestion, and I've already talked that through with Mr. Yardley, and I'm sure we can accommodate that as well. So first, we do appreciate Senator Sanborn bringing this bill forward. We do believe that just as last session's committee, this committee will appreciate the consumer benefits as well as the clarity in the statutes. And with that, we urge the committees ought not to pass support for the bill. And I would be happy, Representative Tepler, to answer any questions the committee might have. And I can't.
Mr. Garrity, did you just say ought not to pass the bill or ought to pass?
Well, if I did, that was a mistake. I ought to pass.
Okay, that's what I
I'm
thought.
more used to saying ought not to pass, but in this instance, it's ought to pass.
Yes, I just wanted to clarify that. Okay. Does the committee have any questions for Mr. Garrity about the travel insurance bill? Seeing none, thanks for your testimony. And next up is Mr. Yardley testifying in favor of the bill for the Bureau. Welcome, Mr. Yardley.
Thank you, Representative Tepler, Senator and sponsor Sanborn, and members of the committee. I want to congratulate you on your stamina. I got some amusement from Mr. Garrity's confusion. I think we're all exhausted. Anyway, I'm Ben Yardley. I'm senior attorney at the Bureau of Insurance. I'm here to testify in support of this bill. Mr. Garrity accurately described the prior proceedings and our involvement with them. We do have with respect to the revenue comment, we're happy to see the one statute that they want to, the one part of the bill they want to take as their own related to taxation. And we do support the consumer disclosure and sales practices requirements. We have a couple of comments to make, which I think are appropriate to review briefly, but I would say that I expect we could work easily on language and present the committee with something in short order for consideration. Proposed section 7053 sub 1 says that licenses to sell, solicit, or negotiate travel insurance are governed by this subsection. We recommend striking that language, which appears on page 4, lines 39 through 40, to preserve the limited lines producer license option that exists under Chapter 16 of our licensing. That's our licensing chapter. The proposed language in section 70541 states that brochures and written materials provided by the STIP and travel retailer must have been approved by the STIP. We suggest making these materials subject to approval by the insurer who issues the coverage, the coverage. The STIP is shorthand for the supervising travel license producers. It's a producer, not an insurer. And proposed section 7058 sub 2 identifies the elements in fulfillment materials. We recommend that this the word must be included on line 38 at page 7. And last, the proposed 7056 would require travel rates to be filed. We recommend that the language be amended to require the superintendent's approval, which is consistent with other lines of insurance and addresses an issue with respect to inland marine insurance, which I think Mr. Garrity described travel as being part of. So with that, I'll be happy to try to answer any questions either now or bring you information at the work session and close out.
Thank you very much, Mr. Yardley. I assume that that will be delivered in writing, so our analysts can work with those issues along with the sponsor and Mr. Garrity.
Do you mean that our testimony didn't reach you?
No, we do have it. I'm not sure. I just wasn't sure if the things you just mentioned were all.
No, well, I'll work with Mr. Garrity and Colleen to get those put in writing for you.
Thank you.
You bet.
Thank you. Any questions from the committee for Mr. Yardley about his testimony? Seeing none, thanks for your testimony. Appreciate it. And is there anyone else in the Zoom call who would like to testify on LD 1563, an act regarding travel insurance in the Maine Insurance Code? Seeing none, I will close that hearing and turn the gavel over for the last hearing of the day to Senator Sanborn, if she's willing. And also note that Senator Stewart is not with us, but Representative Morris has his testimony available.
Great, thank you. So the last public hearing for today is LD 1628, and it is an act to exempt nonprofit agricultural membership organizations from insurance requirements. And I will invite Representative Morris to deliver Senator Stewart's testimony.
Thank you, Madam Chair. Senator Sanborn, Representative Tepler, and colleagues of the legislature's Health Coverage, Insurance, and Financial Services Committee. I'm actually not Senator Stewart. You know, I'm Representative Morris, but I am presenting his testimony for you today on LD 1628, an act to exempt nonprofit agricultural membership organizations from insurance requirements. The legislation would permit a nonprofit agricultural membership organization providing healthcare benefits to do so for the organization's members, their dependents, and others. Rather than be insured through a typical insurance company and plan, an agricultural membership such as the Maine Farm Bureau or others would be able to provide this important resource to its members. The passage of this legislation would not require that members of these organizations receive healthcare benefits from that organization, but as paying members, they may feel that it is a better option for their personal case. The legislation is modeled off of other states that have successfully allowed membership organizations like farm bureaus to provide health coverage to their members. The goal of this legislation is to target those who are working and don't qualify for any subsidies on the exchange, nor any government plans. At the same time, these people don't make enough money that providing coverage for their families is affordable, given that they typically have a high number of dependents in larger farm-based families. For these people, they are left without options until now. Given the structure of the risk pools of these individuals, typically working age, who are mostly healthy, the cost to insure that risk pool is lower for a group like a farm bureau. They also have the ability to select who is able to be included in the plan, which helps to control costs from a high-risk individuals who would be able to access the exchange or other more attractive options regardless. To be absolutely clear, this bill and this type of plan is targeted at ensuring the people who have been left out by state government's past attempts to ensure every Mainer has access to affordable health coverage. While there may be some resistance because it would no longer be regulated by the Bureau of Insurance, I feel this is a decision individuals should be able to make. The passage of this legislation would not require that members of these organizations receive healthcare benefits from that organization, but as paying members, they may feel it is a better option for their personal case. The families who this bill would impact are some of the hardest working people that we represent. They show up every day, put in long hours, and want to be able to take care of their families. We should grant them that opportunity by allow for interested groups, some of whom you'll hear from later today, to provide a product that works for them. Thanks for your time and consideration for this important legislation.
Thank you, Representative Morris. Next, we will hear from Courtney Hammond from the Maine Farm Bureau. Good afternoon, Mr. Hammond, go ahead.
Good afternoon, Senator Sanborn and Representative Tepler, members of the committee. My name is Courtney Hammond, and I'm a blueberry and cranberry farmer from Harrington, Maine, which is in coastal Washington County. I'm one of the co-presidents of the Maine Farm Bureau, and I just want to say right up front that an insurance specialist I am not. I have participated in some meetings with some of the other state farm bureaus that currently participate in this program, and I think that it's an option for some of our farm bureau members here in Maine who, for the most part, don't have health insurance coverage because of the cost associated with the marketplace and the increases that have happened with marketplace premiums over the last several years. you know, I'm paying as a farmer with just my wife and one young son still in elementary school. The only thing that I can afford is an HSA plan, and with a high deductible, and with the marketplace, I'm currently paying almost $23,000 a year, you know, for the HSA, and that's a deductible that's like $7,400. And looking at these Farm Bureau plans that are offered in some of the other states, Tennessee being kind of the leader of the group, and then it also includes Iowa, Indiana, and Kansas currently. Their members that participate in this plan can save sometimes as much as 77% over the marketplace premiums for a similar coverage. The coverages are like health insurance. They offer preventive care, hospital care. There's a prescription plan. There's a Medicare option for those folks that are older. So it's very similar to health insurance, although it's a shared health cost program for Farm Bureau members. LD 1628 would allow Maine Farm Bureau basically to partner with these other states and allow our members the option to purchase this health coverage as opposed to being in the marketplace. I wanted to hit a couple of bullet points about the coverage. Unlike health insurance, there's no lifetime benefits imposed on any of the plan options. You don't have to get a referral to go to a specialist. And again, like I mentioned, there's prescription drug coverage and preventive care coverage. It's not guaranteed coverage for everybody that signs up, although statistically about 90% of the people who apply to the program are offered coverage. There's a guaranteed renewability once you're in the program, and your coverage can't be terminated because of medical claims. There's also no open enrollment program that's limited. You can sign up at any time during the year, and the plans are portable from state to state as long as the person remains a member of those farm bureaus. It actually has a wider provider network, has more providers than the ACA. And here in Maine, where there's only 3 options for coverage in the marketplace, it would give us another option for those farmers. As far as, you know, this plan having an effect on other health insurance options around the state, in the other states that have participated in this program, the farmers that are there currently don't have health insurance because of the cost. And so about 83% of the people that participate in the Farm Bureau plan wouldn't have health insurance otherwise if it wasn't for this program. And with that, I'd be happy to answer any questions.
Thank you, Mr. Hammond. Are there questions for Mr. Hammond? All right, seeing none, I'm next going to call on Julie Ann Smith.
Good afternoon, Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Julie Ann Smith, and I am the Executive Director of the Maine Farm Bureau Association. I don't appear before your committee, so I just wanted to explain a little bit who we are. We are a nonprofit, nonpartisan, grassroots, statewide membership organization that was formed in 1951 to speak as the collective voice of the thousands of farmers throughout Maine. Each year, our farmer members meet to discuss, decide, and prioritize policy for our organization. One of the biggest discussions over the past 5 years has been the increasing and unmanageable cost of health insurance. I'm grateful to have the opportunity to serve as the voice of our farmers today to support LD 1628. Agriculture in Maine is struggling. In the past decade, we have seen a loss of nearly 10% of our farms, a decrease in the average size of acres farmed, and an overall loss of land in agricultural production. Maine has a very short growing season with very high production expenses, making profitability for farms very challenging. Production expenses such as seeds, fertilizer, machinery, and labor are costs that must be paid for before the farm owner can be paid. While this is similar to many businesses in Maine, the difference for farmers is that they are price takers. Farmers cannot set what price they will be paid for the food they grow, and Maine farmers are competing with international imports and even farms in other states that are able to grow crops and ship them into Maine for less than what it costs a Maine farm to produce the same vegetable. Maine imports 90% of its food to meet the consumer need for inexpensive food. This leaves many farmers in the gap of uninsured. As the COVID-19 pandemic has shown us, production of local food is imperative. We cannot predict when the next disruption in the food supply chain will happen. If we cannot find a way for more Maine farms to produce more food, we may find ourselves in a very dire situation in the future. This bill would address one aspect of farm expenses that are forcing farms out of business: health insurance costs. In researching options for Maine's farmers, I discovered that several state farm bureaus, Tennessee, Iowa, Kansas, Indiana, South Dakota, and New Hampshire, all offer affordable health coverage options to their members. These innovative programs, which have received bipartisan support in other states, provide an alternative to farmers that are unable to afford the high cost of a conventional insurance. Tennessee Farm Bureau, for example, is able to offer affordable coverage with premiums that are up to 70% lower than what is available on the individual market and offer more affordable deductibles. They have a 98% renewal rate, and a consumer with a complaint about coverage does have recourse through the Tennessee Bureau of Insurance. My understanding is that the Tennessee Health Plan does have to maintain actuarial review, and it is a plan that has been successfully saving farms money for nearly 30 years, and more importantly, has allowed farm workers to have consistent coverage regardless of employment status. This is very important as many farm workers do only work seasonally. So this allows them to be covered year-round, regardless of whether they are working on the farm. There are too many farmers in Maine that delay preventative care because they cannot afford the upfront cash costs of their current deductibles. We all know the huge cost to our health care industry when preventative care does not happen. With a Farm Bureau plan, a family of 4 with 2 parents in their early 40s and 2 kids under 14 would experience a savings of nearly $10,000 per year. This $10,000 is easily an amount of money that makes or breaks a farm. We respectfully urge the committee to vote ought to pass to provide farmers with an affordable alternative that would help keep farms in Maine operational. I do want to bring to the committee's attention that Tennessee Farm Bureau would be more than happy to be present for the work session to answer any specific questions. I am not an insurance expert, but they are available and would be happy to do so. And I'm happy to answer any questions you may have today.
Senator Brennan.
Thank you, Madam Chair. Nice to see you, Ms. Smith. I'm a Farm Bureau member. I'm curious if you could tell me a little bit about your membership. How many members do you have?
So we currently have 1,100 voting members. Voting members are members that are farmers that earn 51% or more of their income directly from farming.
And can you tell me a little bit about the business structure of most of your members' operations? Are they DBAs? Are they corporations? Are they LLCs?
I believe, I'm going to guess here, most of the farms that I've talked to are S corporations, but I would hesitate to say that that would be the majority of their structures without getting more specific information from the farmers directly.
So you talked specifically about this idea of the family farm. Can you tell me a little bit about how this legislation would affect the employees on the farm?
This would actually allow more farms to offer health coverage to their workers, because most farms right now do not offer any sort of health insurance. And so because this allows the workers to be insured independently of the farm, as a farm worker, they are certainly eligible to be a Farm Bureau member. And so then they would have an independent policy.
But not through their employer?
Correct, it would be through Farm Bureau.
So the farm corporation's capacity to insure their employees is not an option through the Farm Bureau with the legislation you're proposing. Is that what you're saying?
No, they,
So I'm an S Corp, so my employees would have to become members of the Farm Bureau in order to be able to access this if we were to enact this.
what we have done previously with insurance, the insurance program that we used to have, was that the farm would pay for the memberships of their employees and then pay for their insurance that way. So it's a little bit different than being directly paid for, insured through the business. So it would allow the farm worker to continue that policy were they to go move on to another farm or move outside the state.
And what's the average age of your member?
Most of them are, well, we have kind of a gap. We have a very large number of young farmers, and then we have a lot of members over 50. So we're kind of missing between 40 and 50.
And why did you choose the year 1951 in the legislation?
That was the year we were incorporated.
So what about other organizations in the state that are younger, that are membership organizations that represent farmers, like MAFCA?
Well, we were really only familiar with other state farm bureaus, and that was how they structured their legislation when they had it passed in their states. So we were simply using other states as a model.
Okay, thank you.
Thank you.
Representative Quinn.
Yes, thank you. You were speaking about Tennessee.
Representative Quinn, you got put on mute there for a second. Try again.
Okay, here we go. You were speaking about Tennessee earlier, how they handled complaints. Can you speak a little bit more about that, please?
I would be happy to repeat what they have told me in our meetings. I am by no means an expert, and I would be happy to have them present for the work session so they can speak directly to it. But they did have an agreement with their state insurance bureau, so that anyone who had a complaint could file that with the state bureau. So they weren't completely unregulated, is not the right word, but there is still recourse for the insureds. And from my recollection, since 1993, they have only had 2 complaints filed against them.
Thank you.
Representative Artford.
Yes, thank you, Madam Chair. And thank you, Ms. Smith, for being with us. Quick question. I'm curious, in reading over the bill, it doesn't really describe the actual health plan or whether or not there's more than one actual health plan that's being offered here. Is there a number of different packages? Is it one package? How comprehensive is it? I'm just curious.
Those would be great questions for Tennessee Farm Bureau, but they do offer multiple packages. I can't speak to their specifics, but from my conversations with them, the highest deductible plan is only $6,000 per year, and they have found substantive monthly savings for everyone who is eligible under their plan. So that there are different levels of coverage that members can choose from. But I would not be able to speak to the specifics of those.
Thank you.
Thank you.
Thank you, Ms. Smith. Ms. Smith, it sounds, so this is the insurance committee. We don't hear from the Farm Bureau very often, as you said, but we do hear a lot about insurance. And one thing I'm pretty clear about with insurance is that you can't magically make rates go down 70%. Unless what you're paying for it isn't the same product. So I would like to have a little bit more understanding of what it is that the Farm Bureau wants to sell.
Certainly. And I will be happy to have Tennessee Farm Bureau present for the work session to answer all of those specific questions.
Okay. The other thing is that the bill as written asks us to define something that is clearly health insurance as not health insurance. Do you have an understanding of why that's the structure of the bill you need in order to proceed here?
I do not know the specifics of that. Again, that would be a question for Tennessee Farm Bureau, because I am not a health insurance specialist, unfortunately. This has been a challenge for me to try to comprehend how all of this works and comprehend why my farmers are choosing not to be insured because they can't cover the cost of it.
Okay. And are you familiar with the concept of a Maine Employee Wellness Association? Or a
I'm not.
Employer Wellness Association? Okay. So that's a MEWA, and that's the process under Maine law by which associations can form health plans. So I definitely encourage you to look into that a little bit more. Are there any other questions for Ms. Smith? All right, seeing none, thank you for being here. And next, we'll hear from Percy Lorette. Good afternoon, Mr.
Hello?
Lorette. Go ahead.
Hi, can you guys hear me all right?
We sure can. Go ahead.
Okay, hi, I'm Percy Lorette. I'm a young Maine farmer, 22 years old. I was asked by Stasha Baldwin, she's the head of Young Maine Farmers and Ranchers Committee, to speak on this bill today. And one thing I guess I would like to say is that myself personally, I have no health insurance. And probably one of my biggest limiting factors in agriculture and working on my farm is cost of things. It's really hard for me to justify, up to $10,000 a year or something like that on a health insurance plan when $10,000 could be easily spent, in infrastructure and other things to better my abilities to farm. And like I said, I don't have health insurance. I've had, instances when I've gotten hurt on the farm, small things. But I always try to avoid going into, urgent care or the hospital, if I can, just because of the cost of it. It seems like most of the time when you go in there, you can spend $1,000 awful quick. And so, I really, hope that there is some options, either through Maine Farm Bureau or, other programs to get people like me, to be able to have a health insurance coverage. I'm working with dangerous things all day. Things can always go wrong. And when it does, it's not very fun when you have to choose, okay, where do you want to spend your money? Especially, I'd love to have a set of glasses, but, to spend $500 on them right now, right in the spring, is a really hard thing to do. So I think there's a need for this.
Thank you, Mr. Lorette. I have a couple questions, and then there's other members of the committee that have questions as well. Our clerk needs to know what town you are from for our log of who testified. Can you let us know that?
Yeah, I live in Bradford, Maine.
Excellent. And my question for you was whether you had ever shopped for health insurance on healthcare.gov and checked out whether you might be eligible for subsidies.
And I haven't. I've actually kind of always assumed it hasn't been an option. It would have to be really cheap for me to be able to justify it, I guess.
Yep. Definitely understand that. Want to suggest to you that you just log on to healthcare.gov because most people are finding plans for about $10 a month right now. And okay. that would be my guess as to what you'd probably be eligible for. So I just wanted to suggest that to you if you haven't checked it out. The subsidies just got better over the last few months. So I just wanted to flag that for you, Mr. Lorette, because you work in a real dangerous industry, and I want to make sure that you can take care of yourself and get the healthcare you need. So just wanted to check with you on that. Senator Brenner, go ahead.
Thank you, Madam Chair. And thank you, Mr. Lorette, for being here. I'm curious if you could tell me what you grow.
So I am a grass-fed beef operation. I have a small herd of cow-calf for my personal self, and I'm also the farm manager for Heartstone Farm. And we're a direct-to-consumer online e-commerce business. We ship to 34 states. We'll process over 350 head of cattle this year is what we're planning on. And we work with Tide Mill Organic Farm in Edmond. They raise our chickens that we sell online. And we work with North Star Sheep Farm down in Wyndham, and they sell lamb to us.
Thank you. As a farmer, I last year paid $36 for my family of 4 to be insured on the ACA. So I would strongly encourage you to check that out when you have an opportunity to be online. It's healthcare.gov. So I would second Senator Sanborn's recommendation. I think you'll find success there.
Okay, and I guess I will say that I'm surprised that no one had ever mentioned that to me before. I guess I just wasn't aware that there was, maybe some, cheaper options.
Mm-hmm. Thanks so much for your words today, taking time out.
Welcome.
Thank you, Mr. Lorette. Thank you, Senator Brenner. Representative Quint, go ahead.
Hello, thank you for being here, Mr. Lorette. I love seeing young farmers. I'm from an agricultural community as well, and I'm a nurse in that community, and I've seen some of the accidents that you're talking about. And so I would definitely suggest you look into some of the insurance plans that they talk about. But I am very optimistic and interested to hear about what we can do with the Farm Bureau as well. I know that it's worked in many states. I've lived in other states that have had the Farm Bureau very involved, and an uncle out in Nebraska involved in that. So once again, just thank you for being a part of the political process and voicing your age group in our committee here. We really appreciate it. Thank you.
You're welcome.
Representative Tepler.
Thank you, Madam Chair. And thanks for being here, Mr. Lorette. And I just want to suggest that if you do go on healthcare.gov and you find a plan that you can afford for like $10, $15 a month, I hope you'll share that information with other young farmers who might also not know that there's federal subsidies that are going to help you be able to afford insurance, particularly if you're a young farmer.
I will. Thank you.
Thank you so much for being here, Ms. Lorette, and thanks for continuing the farming traditions in the state. Next, we'll hear from Lisa Turner.
I'm not sure. Oh, there's the camera. All right.
Welcome.
Thank you. I figured it out. Senator Sanborn, Representative Tepler, and members of the committee. My name is Lisa Turner. I live in Freeport, and I'm the president of the Maine Vegetable and Small Fruit Growers Association, and we are in favor of LD 1628. I will use my husband and I as an example of the current state of health insurance on the private market. Before the Affordable Care Act, the ACA, we paid about $6,000 per year for coverage for our family of 5 with a $15,000 individual or $30,000 total family deductible / out of pocket. Those deductibles were staggeringly large, but the premiums were relatively affordable. Last year under the ACA, the premiums for just my husband and I, the kids are on their own now, was $20,000 with a $6,500 per person deductible. If we used care that was outside of the preferred provider network, we would start at zero and have to pay an additional $12,500 of deductible before the insurance covers anything. And that's only because we chose the only plan offered in Maine that has any kind of coverage if you're outside of the preferred provider network. Because $20,000 of premiums is entirely unaffordable for us, we've had to make sure that our income stays below the level that allows us to get subsidized care, which is 4 times poverty level, or about $67,000 for us last year. With the subsidies, our annual cost for the premiums was $1,800 instead of $20,000. If we earned $1 over the allowable amount, we would have had to pay back the entire $20,000. This has kept us from growing our business and has made it very challenging to be able to save money, as nearly all of that income goes towards paying our bills. This month, my husband turns 65 and qualifies for Medicare, which you would think would be a good thing. But as it turns out, you have to pay premiums for Medicare. So our total annual premiums double this year from $1,800 to $3,600, assuming we continue to receive the subsidy for my health insurance. I have asked my accountant if we need to keep our income level under 4 times poverty level for a family of 2, or if it's now for a family of 1, since my husband is covered by Medicare. The income limit for a family of 1 is a mere $51,000, and I don't think we can pay our bills on that, but I don't know how we can afford an additional $10,000 for health insurance if we exceed that income level. The system is so convoluted that my accountant has yet to give me an answer. Now that tax season is over, I have high hopes that he'll figure it out, but so far, none. While the ACA has been a godsend for some people, for others, it's an anchor around our potential. Given the choice of $1,800 per year or $20,000 per year just for the premiums, what choice would your family have? We're far from being the only farmers who are affected by this. There are many others around the state. The Maine Vegetable and Small Fruit Growers Association urges you to vote yes on LD 1628 and give farmers a chance to make a better living for their families. And I'm happy to answer any questions.
Thank you so much for being here, Ms. Turner, and thanks for continuing our farming traditions as well. And I just wanted to give you the information and anybody else who might be listening that that the rules recently changed and there is no more cap at this time on the income that you can earn and still have subsidies. It was just eliminated under federal law in March. So your accountant might not have incorporated that, or that might be why he hasn't gotten back to you yet, as he's working his way through tax season, or she is working through their way through tax season. They may not have wrapped their heads around that piece, but it should be good news for your family going forward, because there is no more cliff on the subsidies. And I agree with you that that was a flaw in the ACA, particularly as as subsidies went up. But I wanted to take that moment to actually let you know that piece of information, because it could be really critical for your family, and it just changed under federal law just in March.
Thank you.
Yeah, Representative Quint, go ahead.
Thank you, and thank you, Ms. Turner. This is actually a little bit more of a statement to Ms. Turner. I really appreciate the way that she explained it. For anyone listening in, they were able to understand what the flaw was within that system. So just thank you for speaking to our committee today.
Thank you.
Representative
Tepler. Thank you. And hi, Ms. Turner. My daughter used to work for you.
I know. I remember her.
Yes, and yeah, I mean, we appreciate your vegetables, so I hope you'll keep farming, and I hope that the changes in the ACA will enable you to grow your business and hire more young people to learn farming from you. I think that you're right, that cap was really problematic, particularly for being able to grow your business, and truly hope that this change will make a difference for you and for lots of other people who are trying to grow businesses and stay insured.
Thank you.
Mm-hmm. The other thing I'll just let you know is you would not have to pay anything back for 2020 either. They eliminated that rule. So if you did make too much money in 2020, you won't have to pay anything back, which is also a really nice feature.
Of course, they didn't say that until the end.
That's true.
So you had to know, or you were. I mean, I can't suddenly owe somebody 20 grand. It's not like that can't happen. I have to plan ahead, and they didn't decide to let me know that ahead, so that didn't help. But I did know that they took that away, and it was like,
yeah. So great. Well, thank you, and I am really pleased to be able to share some of these changes with the ACA that I think really make it a much better program and should help more Mainers. So thank you so much, Ms. Turner, for being with us and telling your story very clearly, as Ms. Quint, Representative Quint indicated. I totally agree. Representative Tepler, you want to say something else? You're on mute.
Thank you. Sorry. Yes, I would if possible. One of the concerns that came to me as Ms. Smith was talking about the plan that they have in Tennessee, or maybe it was Mr. Hammond, I'm sorry, I can't remember which one, mentioned that there was no lifetime benefit on the plans that they were talking about, which means that I believe that those plans can impose caps.
Is this a question for Ms. Turner, Representative Tepler?
Well, I wanted Ms. Turner to understand that it's possible that she wouldn't get the same quality of care under a plan that was organized like the one that has been suggested by the agricultural organization. And that was just what I was attempting to say.
We
Thank
just
you.
don't go to the doctor. We just don't use health care because we still have a $6,500 deductible. I mean, every time we go, we pay everything. And there's no dental and there's no eye care. So that's on top of that $6,500. So we just don't get sick. We've found all kinds of different ways to deal with our health without going to the doctor. My husband had blood sugar in the diabetic range, and that was going to be $6,000 a year for the medication. And so now he never eats a carb so he can keep his blood sugar down, because there was no way we had $6,000 to pay for that. So to tell me that I'm not going to get as good health care, I can't imagine it can be any worse. This is not good coverage. So anyone who's thinking that is not what this is. This is still catastrophic care. And I pay, we believe in health insurance. Every year that we pay more than we use, we won because we weren't sick and some other poor person was. And I'm very clear on that. And I don't mind paying some of it. And I certainly wouldn't mind paying more than $1,800 a year as my fair share, but $20,000 for two relatively healthy people who just practice doctor avoidance is not a fair share. So I'm perfectly happy to accept a lower quality service than what we're doing now, because we don't go anyway. I really just need the catastrophic coverage.
Thank you, Ms. Turner. Are there any additional questions for Ms. Turner? Seeing none, is there anyone else who wishes to testify in favor of the bill? Seeing none, we'll turn to those who wish to testify in opposition to the bill. And I'm going to start with Kate Endy.
Thank you, Senator Sanborn, Representative Tepler, members of the committee. My name is Kate Endy. I'm the Policy Director at Consumers for Affordable Healthcare. Nice to see you again. And here today to testify in opposition to the bill. Before I start, just want to mention that for those who are looking for help navigating their coverage options and what they're eligible for, we also run the state consumer assistance program for health insurance and provide free assistance to people in helping them determine what they're eligible for and helping people apply for coverage, including the marketplace subsidies and insurance. And our helpline number is 1-800-965-7476. So with that, I just will jump in. I think this committee has previously taken up other bills for non-ACA compliant coverage, short-term insurance, for example. And these plans share many of the same issues that have been discussed in those hearings. I know you've had a long day, so I'll try to be brief, but including pre-condition exclusions, benefit caps, deductibles that are much higher than what is permitted under the ACA, although I recognize that sometimes those are too high for people as well. I know Senator Sanborn and Representative Upper and others have already shared that there have been federal changes. And I would just highlight that with those federal changes, it's estimated that over 16,000 Mainers who were previously uninsured are now newly eligible for subsidies. And those who were previously eligible for subsidies are now eligible for larger subsidies. And so what we have found is with many of the clients that we've worked with, a lot of affordability barriers have been significantly reduced. And I certainly, although we oppose the bill, certainly appreciate and the sponsor's intention to expand access to coverage that's more affordable for people who have fallen through the gaps. However, we see this as potentially counterproductive to that goal by pulling younger or healthier people out of the individual market that would contribute to worsening of the overall risk pool for those who do need comprehensive coverage. And I think that's, we have seen that previously when non-ACA compliant plans were introduced or expanded. As an example, when short-term plans were expanded in terms of being able to enroll in those, Maine's rate filings included that as a factor for increasing premiums in the state. And so I just wanted to flag that as well. And we'll be submitting written testimony with more details, but happy to answer any questions.
Thank you, Ms. Endy. Are there any questions for Ms. Endy? Representative Quint.
Hi there. Hi, Ms. Endy. You actually brought up one of the points of the younger working farmers who obviously are more physically fit, having lower costs for their health insurance. And this is something that goes into the Farm Bureau pricing. Senator Sanborn brought up earlier how they're able to price it for much lower. That is something that they should actually be able to benefit from. So you're testifying against them being able to do that to offset the cost of others. Am I hearing you right?
Well, so currently for a qualified health plan under the ACA and Maine law, carriers can provide lower rates to people based off of their age. So younger people typically do qualify for lower insurance rates already. For people who qualify for subsidies on the marketplace, sometimes that differences are mitigated because those subsidies are provided based off of your income level. And so, but if you look at the base rates, there are already differences. I know there have been, bills heard in this committee around community rating. And so, those differences are, largely what that would address. But I think what that would do, if you put all of, young people, healthy people without pre-existing conditions, and you only provide coverage to them, and the only people who would pay for the more expensive comprehensive coverage are people who really need it. And then it becomes increasingly unaffordable for those people, which is why having the largest possible risk pool possible is typically beneficial, because then it helps balance out those needs. Because, the overall purpose of insurance, at the fundamental level is to spread that risk across many people. So that way, you pay a little bit each month, and then when you need it, it hopefully is going to be able to help pay for those unexpected expenses. And so that's what I see as the problem there. And I'd also just point out that the language doesn't appear to limit enrollment in these plans to farmers or people working in agriculture. It seems to be fairly open. And so that's just
Representative Quint has a follow-up. Go ahead, Representative Quint.
Yes, no, she did answer the question. Thank you. I think it had a lot to do with the fact that they were Farm Bureau members, but once again, being able to have a lower cost because of what their standard of living was and how they earn that living. So I was just, making sure to clarify that for myself. So thank you.
Thanks. I have Steve Butterfield signed up to testify next, but I don't see him on the call. So we will move on to Dan Bernier.
Dan's not here either. He had to leave for an appointment, so he
Okay.
submitted he'll submit written testimony.
Perfect. Thank you, Colleen. So we'll finish with Superintendent Chapa. Good afternoon, Superintendent. You're batting cleanup for us this afternoon. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and I'm aware of the length of the hearings today and yesterday, so I too admire your stamina, and I will try to be brief. And first of all, I'm here in opposition, but I'm not unsympathetic. This is a very real problem they're describing. Unfortunately, I don't think this is the solution that is drafted. You know, the main insurance bureau, one of our fundamental goals is to make sure insurers can pay their claims. It's called prudential regulation or financial regulation. We devote significant resources to making sure the consumer is made whole, is kept out of make sure that the carrier can pay their bills. Here, the way it's outlined is total exemption from that. It's a black hole in terms of the financial stability of this organization, what it would look like. And unfortunately, there have been cases that you mentioned MEWAs, Senator Sanborn. The Bureau of Insurance regulates MEWAs, and that is a rigorous and very structured program where we analyze the financials capability to make sure claims get paid. In this case, unfortunately for MEWAs, there are several unregulated MEWAs. There have been several instances of MEWAs failing, consumers left holding the bag. In fact, there was one agricultural co-op called Sunkist Growers where that happened. Again, the consumer protections are very important, but most importantly is the ability to pay claims. And we would have no one, the way the bill is structured, we would have no way of ascertaining whether or not this entity could pay claims and the consumer could be left holding the bag. Another issue that came up is how underwriting young people would benefit this entity. It's Representative Quint's question. Really, the answer is if you can exclude older people from the risk pool, everybody else has to play by guaranteed issue. That means anyone who applies gets a policy. In this case, even the MEWAs that we regulate, if this went the structured MEWA route, if farmers tried to organize a MEWA under Maine law, they would have to take all farmers that applied to them, irrespective of age or health. In this case, the underwriting is left strictly to this entity, and they could just take the healthy people, and that's not that is one, an unfair competition, but the benefit wouldn't. The vegetable grower, she may not be able to get coverage under the underwriting rules they established here. So it's complicated, but again, it's a very real problem the farmers have. And if they're interested in trying to establish a MEWA, the Bureau would be welcome to meet with them and see what we could accomplish. With that, I'd be happy to answer questions. I tried to issue the points that I heard and went off script. But,
You did a great job of ad-libbing, Superintendent Chapa, and answering the issues. So I do appreciate it. Can you speak to the issue of why the bill defines something that is clearly insurance as not being insurance? Why is it doing that? Why is it taking that approach?
Because in Maine and every state, it's illegal to sell insurance without a license. And the license is not just purely administrative. Again, you have to meet the consumer protections. You have to have capital behind the entity so you can pay your claims. And it's against Maine law for a good reason to sell insurance without a license. And because there have been several instances, or multiple instances throughout the country of people selling insurance without a license, and the money ends up offshore and consumers are left holding the bet and claims occur.
If it's defined as insurance, it also has to provide essential health benefits. Is that right?
That's another point. Yes. I mean, you can say I'm providing health insurance, but if you get to choose what's covered, that could be a problem because there's, for instance, I know not in Idaho, there was a case, it wasn't involved with a co-op of this nature, but they had a coverage that was similar in nature, similar in structure. The person needed a kidney transplant. They refused to pay for it. This person went on the ACA, got a kidney transplant, then went back to the coverage she had before. So that was a case of, I think, really illustrative of what can happen. They can go into the fully insured market, get the care they need, and then go back to the cheaper coverage. And that, again, long run, is not sustainable for the fully insured market.
Thank you, Superintendent. Are there any other questions? Senator Brenner.
Thank you, Madam Chair. Thank you, Mr. Chiappa. So I was listening intently to you, but I was also double dipping on the website for the Farm Bureau in Tennessee to look at their policies. And I guess it seems like what's happening on that website is that you don't need to be a farmer to be a member of the Farm Bureau in Tennessee. And they have contracted out with United Healthcare to sell a policy, doesn't cover you until no pre-existing conditions until 6 months in, and no dental service until 6 months in. So you're paying for quite a lot of months before you get any coverage. So if we were to take this bill and move forward and remove the definition of insurance, remove this from the definition of insurance, would we be creating a policy that would be weak for the consumer?
You're creating the opportunity to create a policy, whatever the plan designers thinks appropriate. And, you know, there's some very expensive services out there. Then if you want to sell at a cheaper price, you don't cover those expensive services.
So would we have, like, for example, today's hearing around fertility treatments, would we have the option to mandate that this policy cover fertility treatments?
The bill is drafted, you wouldn't have the option to mandate any treatment whatsoever.
Okay. So it would be what it is.
It'd be whatever they say it is, and that would be, yes.
Okay, thank you.
Thanks, Senator Brenner. Are there any other questions? Okay. I will close the hearing on LD 1628, and we're getting to the end of the road here, so things will be scheduled relatively quickly to have work sessions. That is the end of our public hearings for today. My task, which I've been attempting to do while also chairing hearings and listening to testimony, is to figure out what tomorrow looks like. And so I think I have it, but I also want to reserve the right, if I got something in the wrong spot, to move it around. So I'm gonna read it out here just in case people are listening, because I did promise that I would do that. And then we'll also send a follow-up email after I confer with Colleen to make sure that I haven't mucked anything up. But I think I've got it pretty well. So what I would propose is that we start the morning with a combined hearing on two bills, LD 1681, which is the governor's bill, and LD 1007, which is Representative Libby's bill. Both of those bills, as I see them, are about what you can do using telehealth if you are a provider. So they're about scope of practice under telehealth. One would allow each of the licensing boards to make rules about that, and the other would just put into statute the executive order that provided expansive permission to do anything that you thought was medically appropriate that way. So those are the two bills on scope of practice in telehealth. The next bill we would pick up as a separate hearing would be a bill called, that is usually referred to, I think, as SIPAC. It's LD 863, sponsored by Representative Tepler, and it's a interstate compact on licensing psychologists. which has a lot to do with telehealth. The next two bills we would pick up in a combined hearing would be LD 1194, Representative Libby's bill, and 1361 by Senator Stewart. Both of those, I think, take two different approaches to how to license out-of-state providers to provide telehealth in Maine. So again, I'm trying to clump bills together that are about the same thing so that we can have fewer hearings and not have repetitive testimony. And then we would have the last hearing would be a combined hearing on LD 323, 333, and 849. Which are sponsored by Representatives Perry, Hymanson, and Matheson. And those three bills roughly are all about the definition of telehealth and the insurance reimbursement for it. So each of them talks about telephone only or about payment provisions from insurers. So the bill that's left out is my concept draft 791, which is an empty shell, which may serve us very well because we also may not want to pass a whole bunch of separate bills, but we might want to compile an omnibus telehealth bill. And so LD 791 would be for that purpose. So Colleen, I'm not sure as a matter of practice what we do in terms of opening a hearing on it because it's going to be used as a shell, I think.
Yeah, I don't think we need to necessarily open a hearing, but there was another bill that you don't have on here, which is LD 649, also sponsored by Senator Stewart. Is something happening with that, or did you leave it off on purpose?
That was meant to go under the last list, the definition of telehealth and insurance reimbursement for it. I just forgot to type it into my email.
Okay, good. Yeah, that has a little bit of overlap, but yeah, that's perfect. Okay, thank you.
I think that's right. Oh no, I think.
Yeah, did you want it back?
It's sort of half and half. So I'm not sure. Yeah, I'm not sure exactly what to do with it because it's partially about outside of the state physician's practice and it's partially about telephones. So
it is.
I would like to sort of stick to the topics more than the bill LD numbers. So I don't know which place we'll put it, but we'll send it out in an email to make it clear from the LD perspective. But I think the plan is to really have the testimony, hopefully kind of have some topic headings instead of focusing so much on the nuances of each different bill, if that makes any sense at all. Have I lost the committee or are you guys kind of with me and this is making sense? You're with me. Okay, sweet. Excellent. So by my count, that gives us 4 hearings tomorrow that would cover the substance of 10 bills, which seems more manageable than trying to do 10 hearings and getting confused about the nuanced language differences between some of the bills. None of them are identical to one another, but they do, some of them take similar approaches directionally at least. So that's how I tried to organize them, some with Colleen's help, but then also reading them myself and trying to sort through it.
That makes sense. Same time limit, 3 minutes for people, or?
Yeah, I think where we have managed to kind of sort them into segments, I think 3 minutes is fully adequate to cover each of them.
I think that makes sense. And some people might speak more than once, so that makes sense.
Absolutely. Yep, you're welcome to testify in each of the 4 hearings. But just to kind of stick to the general topic area that each of the bills is about.
Great, I'll get an email out to folks.
Wonderful. Thanks so much, Colleen. And do you have anything else for us?
I don't have anything. I will likely have some language reviews tomorrow. We've gotten some fiscal notes back for some bills that were voted ought to pass and just checking on some of those certificate of need bills. I've got some fiscal notes back on those, so we could do some language reviews potentially if we have time tomorrow. But I think that's it. And then at some point we'll just have to talk about next week because we need to do some sort of request to the presiding officers, but we can talk about that after things finish tomorrow as well.
Okay, I was also wondering if the committee was amenable to it, if we might add a couple of work sessions for tomorrow that are, I think, pretty straightforward from today.
Oh, good. I was going to ask if you wanted to do it today, so perfect.
Yeah,
do it tomorrow.
I think I'd rather do them tomorrow if just for the sake of we don't have the whole committee here. I don't want to surprise anybody. But the two bills that I was going to propose were Representative Lookner's bill, which is very similar to a number of bills we've already voted ought not to pass. And I think would fall in the same category. And then my bill on therapeutic foster care that we were going to request a carryover. And I thought we could vote those two bills pretty easily. Either today, I'm willing to do it today, or we could do it tomorrow. Representative Morris, Representative Tepler, do you have thoughts?
No, either way.
Do you
Probably
want to
tomorrow.
You want to
Better.
do it tomorrow? Okay.
Yeah.
Great.
I think out of respect for the members who aren't present right now, I think that doing it tomorrow is probably a better plan so people know that we have work sessions at the end of the day. I think
Okay.
that's the best idea, although I think we'll probably go late tomorrow, later than today tomorrow, but we'll see.
Yeah, we'll have to see. Dividing it into 4 hearings instead of 10, I'm hopeful that that might actually be efficient. But we'll see. I don't know how many members of the public are going to testify tomorrow, which is what tends to take those long chunks like we saw today.
Yeah.
Okay. I don't see anything else, and I do see lots of text messages about judiciary. So I think I'm going to go to my other assignment right now. And we'll see everybody tomorrow for telehealth hearings.
At 10, correct?
At 10 o'clock. Yep.
Okay,
Yep.
great.
Thank you.
Great. Thank you.
Thanks,